This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 614, recorded on May 15th, 2020. I'm Vincent Draccaniello, and you're listening to the podcast all about viruses. Joining me today from Fort Lee, New Jersey, Dixon Despommier.
Good afternoon, Vincent, and it's a beautiful day outside. Although, how would I know? I haven't been outside.
I can see you across the river. I'm in my office at Columbia.
Oh, you are? Oh.
Came in to change the nitrogen tank.
Cool.
It's my essential job here. Also joining us from Austin, Texas, Rich Condit.
Hi, everybody. 84 degrees in Austin, Texas, and cloudy, headed for 90, looking for rain. So rain is good.
Rain is good.
And from Western Massachusetts, Alan Dove.
Good to be here. It's 75 Fahrenheit, but it's humid and feeling almost like summer, and we might get severe thunderstorms this afternoon.
Fine.
From Southeastern Michigan, Kathy Spindler.
Hi, everybody. It's 66 Fahrenheit, 18 Celsius. It says it's raining really hard right now, but looking out the window, that's not really true. And we've had a lot of rain.
Looking out the window is cheating, Kathy.
It's true. That is very true.
And from upstate New York, Brianne Barker.
Hi, it's great to be here with you guys. It is 71 and sunny in upstate New York.
Cool.
Yeah, very good. Yeah, it's a nice day today. It's here in New York City. There are people all over the place.
Yes,
some of them have face masks. Many of them don't. You wouldn't know that we're on lockdown until June 13th. That's what the governor said. Been extended. If you like what we do, consider supporting us. Microbe.tv/contribute. Joining me today from New York State, Daniel Griffin.
Hello, Vincent. Hello, everybody.
Hi, Daniel.
Hello.
Okay.
Yeah, I'm hanging in there.
Yeah, actually, well, that's a good question to start with. How are you?
You know, I'm in the middle of a 19-day stretch of not having a day off and far too many, nights of call.
Wow.
But I'm actually going to, I think by the time people are listening to this, it'll be the weekend, and I'm actually going to take 2 days off, hopefully, and try to recharge before I go, back into it.
How long are your days?
So they're pretty long. Like, as I mentioned, I'm on 24 hours a day. So, I basically get up 6 or 7 and sort of start at that point. And then, the calls and the consultations go. Sometimes I think it's gotten a little better. There were points when I was looking at the clock and making sure I wrote up all my consults prior to midnight so that I wouldn't be into the next day.
And so what does your day actually consist of? What do you do?
Yeah, actually, that's probably good because a lot of people, wonder what I do. I wear many hats, as people may not know. So the primary thing, I would say I'm a physician scientist. So I spend the bulk of my day seeing patients, consulting with other physicians, coming up with management plans. So on the normal day, my quieter days, I'm usually only going to one hospital. Other days, I'm going to as many as 4 different hospitals. And so what I'll do is actually show up at the hospital, put my N95 mask on in the car before I leave the car, put my over mask, my hat, my full length gown, and then I usually try to start with the people who are not infected with COVID. So I'm always worried about, as careful as I am, infection control issues. Mm-hmm. And then I go and I visit. And the people that are non-COVID, I actually am able to usually spend a little bit more time, do a more thorough exam and address their issues. Because as it's probably good to remind everyone, there are people in the world without COVID. There are other diseases still out there.
So these are people who have been admitted for other issues.
Yeah, so these are people who've been admitted to the hospital for maybe they have bacteria in the blood, maybe they have a bad urinary tract infection. Sometimes it actually turns out it's non-infectious, but I'm involved because the possibility of an infection or the concern that treatments might be dangerous if there's an infection, such as a man we'll discuss who was actually hemorrhaging into his lungs today. And, my role was saying, I don't think this is an infection, but I do think it's a vasculitis. And I think it's safe to do, the immunosuppressive treatment because of the lack of infection. I then see the patients who have COVID, who are, we'll say, active shedding virus COVID patients. And those we try to be limiting in only one person doing a really thorough exam, so that we, again, minimize the amount of infection transmission possibility. And then a lot of times it's actually, particularly in the intensive care unit setting, like this morning, there were 5 of us. 3 of us were there in person. 2 people were, in by phone, all conferencing and discussing the case and what do we think we should do and what are the sort of benefits of this treatment versus that? What other diagnostic testing might we do? And then coming to a decision about the treatment plan. And then at the end of, often at the end of the seeing patients in the hospital, some days I then go and see patients in the clinic. We actually have an office. At this point, we've been seeing patients through telemedicine. So, which is kind of interesting. If anything, it allows us to treat a broader geographic area. Prior to the pandemic, I actually was seeing people until 7, 8 o'clock at night in the office on the days that I had clinic. And then somewhere in here, like just before our call, I was wearing my other hat as the chief of ID for United Health Group, their global research and development division. And so basically talking about upcoming research plans, which had originally been influenza-based, which are now becoming COVID-based. And one of the nice things about United Health Group, I don't know if people know, they're very large. They say the largest wellness group in the world, but they are sort of the parent company of Optum and Optum RX and United Health Care, the insurance company, and ProHealth, my large multi-specialty practice where I'm the chief of ID. And they're working with a lot of people in research who are coming up with hopefully effective antivirals that they want to test during that first critical viral replication period. So that's another hat. And then Columbia has been great about this because I also periodically get time away from this where I'm precepting fellows or seeing patients at Columbia as well. And then there's the research, which the basic science research, which is actually, I have to admit, suffered a little bit in the last month or two here with all the clinical responsibilities.
Sounds like you're a busy guy.
So then he does a TWiV.
Yeah, that I do TWiV.
So I'm curious in the hospital when you're seeing COVID patients, do you see them both in I don't know what you call it when it's not in the ICU? Do you see them on
we would say the general medical floors?
So do you see patients in both the general medical floors and the ICU? And how many COVID? You see more than one COVID patient in a day, right?
Yeah. So early on in the, I guess I'll say during the peak of the epidemic, I was going over this with Thomas, who's actually one of the, I guess he's a nurse manager. Thomas is a really excellent guy who really helps with triaging and figuring out bed utilization and stuff. And we were talking about the numbers, and we reached a peak of 150 COVID patients at the one hospital, where it was my partner in New Jersey and myself. And we were the 2 infectious disease doctors in a hospital with 150 people infected with COVID. That was our peak. And so it was, those were some of the longest days of making sure that you were getting together with the hospitalists and at least an initial infectious disease consultation. And then a lot of, I think, as I mentioned, a lot of it was basically free care where I would meet with the hospitalists and go through each patient, but no way you can write that many notes.
Right. So do you have to swap out your PPE between each patient?
We do, and that's a bit of a challenge. So, for instance, today there was a gentleman who, high suspicion for COVID. We're waiting for the PCR to come back, but he has recurrent left lower extremity cellulitis. So, not only do I put on my whole sort of rigmarole before I get out of the car. But then before I go in the room, I'm over masking. I'm putting on special protective glasses. I'm putting on a full gown. I'm then going and seeing him. And then I'm again going through the whole process of taking all that gear off carefully, alcoholing my hands, wash, the whole. So yeah, there's the part of the day is actually spent doffing and donning, or donning and then doffing all this protective gear.
And one last thing, how full are the hospitals that you work at this point?
Yeah, so things have gotten much better from that standpoint. We're down to, I would say, a quarter of the number of COVID cases that we peaked at.
Oh, wow.
The hospital where I currently am is, I'll say, seemingly a little bit busier because the nearby hospital is trying to do surgeries. They've actually started doing surgeries, and they're trying to do it as a COVID-free facility. And they're doing a good job, I actually have to say. I was worried about that, but no, they're doing an excellent job, but which means that all the potential COVIDs and the confirmed COVID cases are coming to our facility.
People are New York is starting to lift restrictions, right?
Well, I noticed on the way to work today that, boy, there was a lot of cars on the road.
But it's probably too early to see any impact, if there's going to be any, on the caseload that you see, right?
Well, we are all hoping that there's at least some period of time where this lull continues. And for me as an infectious disease doctor, now I'm seeing less COVID, but I'm seeing we'll talk about all these sort of late stage complications that come after COVID. So I'm always busy.
All right. Well, then that brings us to your weekly clinical update, Daniel.
Okay. So, yeah, I laid this. I always like to lay this out so it's sort of organized in how we present it. And I know for a lot of the people that listen to the beginning, a lot of them are clinicians. A lot of them are the pro-health, infectious disease, primary care, other specialists in the pro-health care New York. But I know also we have listeners throughout the country, actually the world. So try to keep this focused on what people need to know. So as we just discussed, all the numbers are looking better here in New York. And I think, Vincent, you threw this in the last TWiV for me, but the famous Irish patient that we were all following, that was actually one of the first patients that actually was treated with the tocilizumab, the IL-6 receptor, and the steroids. He is better. He was
That's
discharged.
Just so awesome.
I have to say, the numbers can be overwhelming, but each person is an individual person. And as a physician, you care, you get attached. And, this gentleman was in the hospital for well over a month. And I, work most days. And so I would see this gentleman over and over again, and how wonderful when he got to the point where he could start to talk, when he had his first drink of water, when he actually, they do this thing called a clap out, where when people leave the hospital, everyone claps and cheers. And so he was discharged from the hospital. He's now recovering in one of the rehabilitation centers. He's getting his strength back. He really lost a lot of strength. And he's a bit of a star on one of the Colorado TV stations. Actually, apparently, you don't know about this because he wasn't able to talk early on, but he is from Colorado, was out visiting. He has a friend who is a female. I don't know if it's a girlfriend. I'll just leave that. But I got to watch this TV segment from Colorado where he and his friend were FaceTiming, and he's now able to talk. He's in the rehabilitation center. He's walking. He actually developed a trigeminal neuralgia, another one of these wonderful late stage complications of COVID. But no, he's getting better, and that is wonderful to see. Yeah. So,
do you know if he is PCR negative at this point? check
Yeah,
that?
so we did do that. He continued to be PCR positive out to day 41. And then he finally became PCR negative. We did PCR. We wait more than 24 hours, do PCR again. He became PCR negative for that second time. And I guess this is the true test in my mind. Do I believe that makes him now immune and he'll never get infected again? I wasn't willing to take that chance. So we immediately moved him out of an environment where we thought he could potentially be exposed to COVID again. And I was super careful with everyone who might come and see him just to keep that risk down, because we don't know at this point.
Yeah.
And we particularly don't know in individuals who've received these different immunomodulators. Does that affect their ability to mount a serology that corresponds to protection? But we'll talk a little bit, I think, about that. But yeah, so we now have more people in the hospital without COVID-19 than in the hospital with active shedding COVID-19. So the current situation, I think I said on one of the prior episodes that I'm going to give some good news. And then at the end, people are like, yeah, when did that happen? Because I missed it. But here's the good news up front before I forget. So the next thing I want to just talk about, and this was something that, sort of now thankful for, is leadership, right? A lot of getting through this first wave of the pandemic was not necessarily having these wonderful magic bullet therapeutics or anything really. A lot of it was the leadership, like people actually really stepping up to make a difference. And I would say I hate to praise any particular individuals because you always leave other people out. But at ProHealth, we have a pediatrician, I think I've mentioned before, who's our CEO. And, I'm a bit difficult to work with. So I don't know, Vincent, if you can attest to that, but I get very, I guess I care a lot. I get very passionate when I'm thinking that something might not be, going the way it should with regard to my patients. So it's probably good if you're a patient of mine, because boy, I will advocate on your behalf and drive everyone crazy. But no, he was really good about when I said, hey, I think we're going to have a pandemic here. I think we need to get prepared. He was just like, all right, and very supportive. So for all of us at ProHealth, that has been great. And Lawrence Schulman, who's chief of pulmonary medicine at ProHealth, he was actually the head of the ProHealthcare core COVID team. And every morning, initially, he would be making these phone calls, updating everyone, the communication. And, we may have a second wave. So part of the reason I'm praising these people is as a model for the importance of the communication and leadership that really got us through this first wave that I'm hoping is going to be in place during the next wave. My fellow ID docs, physicians, hospitalists, ICU providers, the specialists, but also the nurses. I mean, the nurses, they're really the ones in the trenches, right? I mean, serious exposures. When we talk about, I saw a article in the Times, they've discovered that proning and laying people on their bellies is helpful. I think we may have mentioned that on TWiV a few weeks back, but now it's made the Times. So, but when you say, okay, we're going to take this 250-pound man and we're going to prone him, it doesn't just happen. There actually is a proning team at the different hospitals, and these are nurses, and they put on all that garb that we talked about, and they actually get in there as a team, and they take a person who may even be on a ventilator with all these IVs, everything, and actually take these individuals and physically put them belly down. And then, so many hours later, they're going to go back and they're going to physically put them back up again. So I have to say my respect for all the people has really risen quite a bit. So thank you for everyone so far. The next this is the one I get a lot of questions about. And now as physicians, we're all on the front line getting these questions. What about summer camp? What about school reopenings? And, I think we're all getting very used to what is the most common thing that an intelligent physician now says is, I don't know. And, if your doctor doesn't say that at least once or twice in a discussion about COVID, it might be time to switch. Yeah. But yeah, we don't know. And I'm going to talk a little bit about a recent development, which has really sort of made us step back and say, ooh, now we really don't know. So I'm going to talk a little bit about the stages as we're sort of getting into this lull period. So we've all gotten really used to this pre-symptomatic phase, or even maybe this lasts without ever significant symptoms, where people are shedding virus. We have our viral phase. We have our cytokine storm phase, which is usually when they come to see us in the hospital with the trouble breathing. We have our coagulation phase, where we're seeing venous clots, we're seeing arterial clots. They may not have even had a significant enough cytokine storm phase to end up in the hospital, but they might come in with a stroke. They might come in with an ischemic toe. But now we're seeing, and I think a lot of people are probably taken back by this, I know I am, but this late multisystem hyperinflammatory phase that's been mainly described in children. And there was actually a nice case series out of Italy that I just saw, actually not in a preprint, but an actual publication, where they incorporated COVID-19 serology testing. And 80%, so they basically described a 30-fold increase in these vasculitides in children. And then when they actually went ahead and looked, 80% of them had COVID-19 positive serologies.
So what is the symptomology of this? What's going wrong?
So the way the kids are presenting is fever, abdominal pain, and then and maybe the tongue turns red, this sort of strawberry tongue, and it's a disease that was initially described and characterized as Kawasaki's. I'm going to say this is Kawasaki-like because it does appear to be a medium vessel vasculitis, so an inflammation of blood vessels. Okay. We think that it's driven by immunoglobulin, IgG. So that seems to be our timing of being like 4 weeks out, so sort of a late manifestation. This was a game changer in many people's minds because we had always said, the one good thing about COVID-19 is it tends to spare the children. No one under the age of 30 has died of COVID-19. Now that's changed. We've actually seen several deaths in children. From this late hyperinflammatory process. And it's not just the vasculitis we're used to, but there's actually a septic shock type reaction where they become hypotensive. And so several deaths in New York. I think New Jersey reported a death. The UK had a death. Today, when I described that phone call of all of us on the phone, actually, we were talking to a rheumatologist. We were talking to a nephrologist who I actually used to do renal transplant, B1 cell research with. And the rheumatologist and the kidney doctor are starting to see actually what is a small vessel vasculitis in adults about 4 weeks out from this. So this for me is a big game changer in several ways. When people say about summer camps and schools, I was under the idea that, this younger generation, they're lower risk, that something we can figure in the decisions. But boy, if we start seeing more of this in children, that really changes that. And then I worry about, everyone's ready for a vaccine. If we somehow trigger, the wrong IgG, right. Are we going to somehow create, a whole bunch of people that end up with vasculitis? And some of these vasculitides that we're now seeing, we don't know if they're going to go away. We don't know if this is now a chronic rheumatological post-viral manifestation that we're going to be treating. So we've already seen plenty of people with concerns, will their lungs ever get back to where we wanted them to be? But now we're seeing this. So that's
how does IgG do this? Do you know?
I don't know. We perceive it as, that wonderful box of autoimmune diseases that none of us fully understands. But
okay. It's just there's an association between IgG and this happening. Is that the idea?
Well, also the treatment is the children, at least, we treat them with IVIG. And most of them respond to that. There is an IVIG resistant subtype where they require steroids as well. But yeah, we don't quite completely understand, but the idea, the thinking, the theory is that the IgG is targeting something, binding to something, and that's driving the process.
So why giving them IG helps? I don't understand that.
Yeah. So, is there something enjoyable about COVID-19? Maybe because immunology is such a big part of it. But this reminds me, I think you actually had someone who mentioned Niels Jern and the whole anti-idiotype network.
Yep.
But there's this concept. Actually, at one point, about a dozen years ago, I was invited to talk down in Cuba. This is back when we still didn't go to Cuba unless you had a scientific exemption. But there is a thought that if you create an antibody, then you'll create antibodies to the antibody. So when you flood the body with IVIG, the idea is those IVIGs are then hopefully either binding to some of the bad maladaptive IG, or they're actually filling the receptors so that the immune cells can't bind and then couple with that bad IgG. So there's two sides of it, the anti-idiotype network and then the flooding of what we call the FC receptors, which is the receptor that your immune cells are using to then bind to something tagged with IgG.
Got it.
So two theories on it. It's very interesting.
Do you have any sense of how prevalent these complications are in children?
So the tough thing, I would say is it takes time to sort things out, and we've only just really in the last week or two identified this connection. Initially, right, it was the 15 kids that were identified in New York City. And then next thing you know, there were 30 kids at one of the hospitals out here on Long Island, and then, New Jersey, and then Connecticut, and now France, and now Italy. And I think people had it looked, they had made the connection. And so very quickly, the connection's been made. And so one is the numbers are starting to come in. Two is being a late hyperinflammatory phase. We don't know how prevalent it will end up being because it, again, takes a while for this to develop. It may take a while for these kids to then be recognized. And then, if it is fatal, it's going to take time for children, to have that outcome. I'll be reassuring, at least we do not think this is huge. We don't think that this is like thousands of kids. We still have the impression that this is a rare manifestation. And we still have the impression, I would say, that the vast majority of these children will respond to therapy and get better.
Since we're on this, we had an email from Troy who wants to know, he said he had Kawasaki as a child. Are his kids 5 and 6 months at increased risk?
Yeah. So as I said before, I don't know. No, we really don't know. This is far too new. And I think, you could wave your hands and postulate, but we really don't know. And if anything, it's made a lot of us think, as I think you and I talked about, Vincent, before, that maybe Kawasaki's disease has always been driven by coronaviruses. So this may give us certain insight. Let me just hit on therapeutics. Unfortunately, still no great guidance from proper randomized controlled trials. We're still sort of limited and mostly in the dark here. We've started to use remdesivir in the hospital through the limited access program. Nothing that, knocks your socks off or anything. We're trying to use it earlier in disease because there is a limited amount. So we're trying to identify those patients who've only been sick for, 7 to 10 days, as opposed to waiting till after what we think is the viral peak. So hopefully we'll see something. At least it's not anything that, is dramatic. I can't even clearly tell which patients got it or not. But, the impact that they described was a shortening of hospital stay from maybe 14 to 11 days. So we're just starting to use it. It'll be interesting over time to see if at least we're shortening hospital stay. And we don't know about toxicity. We had one woman we gave it to, and she ended up quite sick. But it's so hard to know with this disease, were they going to get quite sick without it? The other that we're using more of, because now there's the expanded access, and there's actually a Mayo trial, plasma. And so it was a publication out of Houston. I should call it a preprint describing the experience in one of the Texas hospitals. And it was actually it was a tocilizumab, steroid, and plasma study when you looked through the patients. And our hope is that plasma will have some efficacy, particularly early on. I think I voiced the caution last time about it really has a lot of coagulation factors in there. So we're certainly hesitant, and we want to be careful during that second and third week when it may drive hypercoagulability. We're fortunately seeing less, liters of vitamins being put into people. We're using UV to clean the rooms, not to treat the people. Just want to clarify that. It's very, basically they shut the room and they put up a curtain and they warn no one to go by. And because we're trying to clean some of these rooms so that we can now take care of people that don't have COVID. But yeah, that's not being applied to people. But yeah, we're sort of, hopefully we're getting a little bit back to the do no harm. We're getting a little bit maybe patient ready for those proper randomized controlled trials. I try to point out to people that even in the old days when we really were rigorous about what got to a phase 1 trial, only 10% of phase 1 trialed tested therapies ever ended up being beneficial. 90% of them were either not helpful or harmful. So I think a lot of us are realizing that. Also, in this late stage, this is sort of back to the bread and butter of infectious disease. We're seeing a lot of people come in with bacteremia, so bacteria in the blood. One of the initial concerns I know people have is, oh my gosh, it's the steroids, it's the immunomodulators. We're seeing this in just good old COVID-19, people that never ended up in the hospital, people that never got any of these therapies. In people with influenza, we often see a post-influenza staph pneumonia or other bacterial superinfections. It looks like COVID-19 has a similar late stage. So don't just write it off as hyperinflammatory. Do those blood cultures, because a lot of folks, particularly Staph aureus bacteremia, looks quite common as a late phase manifestation in these individuals.
Do you have enough remdesivir to treat everybody?
We don't have enough to treat everyone. As I think I've sort of mentioned, I'm not particularly impressed with the. I guess we've treated a couple dozen people so far, and I can't really tell that it's not a silver bullet. It doesn't do anything dramatic.
So I was wondering, under the circumstances, how do you choose who you're going to treat?
Yeah, so it's managed by FEMA. So FEMA actually gives us a list of criteria, and they basically prioritize people. And so priority 1 is people early on. And one of the interesting issues with the antiviral medications, remdesivir, is that most people don't show up during that first 7 days, right? People are out in the outpatient. So that's actually something I think I mentioned under the UHG hat, the United Health Group hat, is we're trying to look at doing studies, because maybe the people that will really benefit from remdesivir, or down the road, hopefully an even more potent antiviral, is people who are at high risk, and then giving them treatment within the first 48 hours, which is where most antivirals have the most efficacy. But yeah, we follow the criteria, but maybe it's good when you say it's limited that it isn't so wonderfully efficacious, because if this was a drug that was a magic bullet and was just saving lives left and right, it would be really hard to have a limited supply and triage it.
So you must have some way of collecting data that might be useful in evaluating its effectiveness as you use it. Is that correct?
There still are remdesivir trials out there going on, but the way we're using it now is more keeping track of adverse events, so serious adverse events, SAEs. So, the woman I mentioned that we gave it to, and she actually then ended up going into renal failure and liver failure and not doing well, ended up bacteremic after that. We report that and we say, I don't know, but this happened to someone who was receiving remdesivir. Right. But no, I mean, we still need really good randomized placebo-controlled trials so that we know what we're doing. Because right now, we have a string of preprints that are in many ways many anecdotes put together without proper trials. We also have what I'm very worried about, which is the sort of before and after. We looked at people during the surge capacity when we were all drowning and things weren't going very well, and now we're going to do something and look at how well they do now when people are a bit calmer and resources are better. And I sure hope people do better, but I'm not sure I would attribute that to the new therapeutic.
Right.
Do you have any impression of this Lancet paper on the triple therapy that just came out?
Yeah, I looked through that, and again, I think maybe we've moved from, we were early on, I think we were just so desperate for good news. And I even remember the original HCQ French study where they had, there's a good virological response. But I think we've sort of gotten back to we actually want to see, improved patient outcomes. So I looked at this and, sort of like, okay, maybe there's some virological impact here, but boy, that is quite a cocktail of drugs we're giving people there.
Also.
Yeah, so that was sort of, and a couple of those drugs we don't actually think are helpful.
Right, so it's counterintuitive even. I mean, interferon, does that make sense?
So that was, I have to say that was the only one that made sense.
Okay.
The lopinavir, ritonavir, I don't think made sense because I think we have the sense now that maybe that's not so effective. But then they were suggesting that if you couple this with the interferon beta 1, again, timing might be an issue here. If you get an interferon response early, maybe that's the kind of response you want. But yeah, if you ramp that up later, we're thinking that's what's driving issues. So this might help us clear virus. But again, what we care about, what we'd worry about is what does that mean for the patients?
So let's clarify this for the listeners. They're calling it triple therapy, and that's 1, interferon beta 1b, 2, lopinavir, ritonavir, and 3, ribavirin. And the interferon then is going to stimulate innate immunity, right?
Yes, I think that's fair to say.
And the lopinavir, ritonavir, those are protease inhibitors from HIV therapy, right?
Yeah, it's interesting, I guess. So, just because I probably have immunologists listening and they're going to be like, Dad, you really let him just say that?
Okay. So go ahead. Educate me. That's fine.
No, just, interferons really are an antiviral arm of the immune system. And yes, it is part of the innate. It's very quick, early acting. And we're thinking that if you had a nice ability to clear the virus with an antiviral, maybe interferon based approach early on, you wouldn't get into your cytokine storm phase 2.
Okay.
Whether or not the interferon 1, interferon beta 1, I mean, there's a lot of interferon 1s, actually. It's interesting. Whether that's really a part of the cytokine storm is controversial, in part because you may not see them in serum levels, but they may be active at a local cellular site control level. So just sort of to put all that, the lopinavir, ritonavir, the lopinavir is really the effective inhibitor, and it's a protease inhibitor, PI, as people may know from the HIV drugs. Ritonavir is coupled on there because it interferes with the breakdown of lopinavir and allows you to dose it. So ritonavir was originally a dosed multiple times of the day protease inhibitor for HIV. It's now used actually as a way of keeping the lopinavir at an adequate level and allowing you to dose it in a realistic manner.
And what's in your mind, the logic of a protease inhibitor having an effect on a coronavirus infection?
I guess it's got a protease. Do you have any logic to add, Vincent?
Uptake?
I mean, my understanding is that the effects on replication are minimal.
Yeah, So I don't think I have any huge.
Okay.
It might be that the ritonavir is actually helping maybe it's helping ribavirin, stick around. I don't know.
Yeah, actually, that's interesting. Yeah.
And ribavirin is a nucleoside analog that gets in other systems gets incorporated during replication, and the virus mutates to death. But the problem, as we understand it with coronaviruses, is that the proofreading function at least decreases the effectiveness of that because it can proofread out the mutagenesis caused by the ribavirin.
Yeah.
So,
Yeah.
But Daniel, you must be thinking of Hep C days before direct acting antivirals, right?
So we used to, and I was sort of wondering, like, I was trying to go through this, try to see, how did the patients feel? But yeah, we used to treat hepatitis with interferon therapy. And basically, you'd explain to the patient, okay, you're going to feel like you have the flu for 2 months. And so here are these people who are not feeling well, and we're going to give you this triple combination therapy. I assume if you're giving them interferon beta 1b, that they're going to feel really sick. Like, you're like, boy, I had COVID-19. Now I have COVID-19 plus whatever you just did to me. But the PCR turns negative a little earlier. I really would want to know before you made me feel even worse than I felt. Like, am I actually going to get some benefit? Am I going to feel better? And so I wasn't sure when I read this triple therapy trial that I got that confidence that I would actually want to ever give this to someone.
I'm sorry, we interrupted. I don't know what else you had to say, but
no, I think that might be it for the overview. I think, and just to give people out there, a lot of the clinicians in the New York area are starting to see patients back in more and more in the office clinic setting, in addition to our urgent cares. We still have quite a telehealth presence, which I think is going to be important because, there will probably be a second wave. So it'll be important to have that ability to go back and forth and to be there for our patients. And I think then the other big thing is that, randomized controlled trials. Here we are months in, and we're still waiting for really good guidance on what therapies make a difference. So, we need to keep our eyes on getting involved in these if we're patients, if we're healthcare workers, if we're providers helping direct patients, because as a community, we kind of need to know what to do.
You have time for a couple of quick questions?
Yeah, I could do a couple.
All right. So Rochelle is an MD who wants to know, is the patient with persistent positive nasal swab, RT-PCR by Quest, considered contagious despite the fact that it has been 2 months since the first positive test and no symptoms?
Yeah, we answer this kind of in the reverse. We use 2 negative PCRs to suggest that they're not contagious. But as I think has been discussed several times on TWiV, we don't know if that PCR is really detecting infectious virus or just remnant RNA. And I was actually at a call earlier with Steve Goff talking about, when someone is still PCR positive and now we're 2 months out, really, does garbage stick around for 2 months? That seems like maybe the viral replication may have gone beyond the sort of 7-8 days described in the original Munich patients, but we don't know. We don't know again.
And then we have a listener in Ireland, Noreen, wants to know if contraceptive pills, thalassemia, and thalassemia traits do increase clotting problems in COVID patients.
Yeah, we are concerned about the contraceptive pills because there is a thromboembolic aspect of this coagulation phase that happens after the second week. So during that third week. So if you are on contraception, I'm not going to tell you to stop. But again, you should reach out to your doctor if you have any symptoms that you feel are concerning for COVID-19, and then coordinate with them as far as what you may or may not want to do should you actually get infected. Because I think this is an important topic to be aware of and to work with your provider in addressing.
And thalassemia, I guess we don't know.
So I wouldn't think with thalassemia that it would increase issues with coagulation. This is one of those traits that probably developed because of pressures of malaria, Plasmodium species. I'm not sure it actually would cause coagulation issues. I'm not sure I would have any reason to think it would. But again, we don't know. We really don't know.
We have a email from Maurice, whose son is a radiologist in France. He forwarded me a CAT scan of a confirmed COVID-19 patient showing faint ground glass shadow. He assures me this would not show up in a standard X-ray. Is that correct?
So that is something we've learned, or it's been reinforced. but we knew this from tuberculosis, I'll say. A lot of times people will have a standard chest x-ray. It looks completely normal. You think all is good. You do a CAT scan and suddenly the world lights up and you're shocked. And so we see that quite often. And it's a problem, right? Because we would love to be able to say, oh, you don't need CAT scans, chest x-rays are fine. They tell you everything you want to know. But we do know that a completely clear, normal chest x-ray may not show you what you end up seeing when you do a CAT scan.
Got it. All right, one last one. This is coming from a few people. Is loss of smell symptom acute enough to be used as a screening procedure that employs a universally detectable odor?
I'd say no. We tend to see the loss of smell. I think the numbers is now it's about 30% of people that test positive for COVID are reporting this. It tends to be associated with milder diseases, but you're missing 70% of people. What really would be interesting is, so they were saying I've lost my sense of smell, but is there a particular odor that people with COVID-19 can't smell? Maybe that's even broader than the I've lost my sense of taste and smell. But at this point, I don't know.
Do you ever see someone with it who has lost their sense of smell but doesn't have any respiratory symptoms?
We certainly do. And we've certainly seen people who they have no other symptoms and all they had, like I felt fine the whole time, but for a period of time, I lost my sense of smell. And actually, we're seeing more of this now that we have the serology testing where people are like, you know what? For 2 weeks, I had no sense of smell. Otherwise, I felt perfectly fine. And now I've got this nice high antibody titer. So I think we're realizing that that's more. And it's interesting. This isn't that my nose is so stuffed that I can't taste or smell. There isn't necessarily a nasal congestion either. It's just a loss of sense or smell. And there's some I think they're preprints, I have to say, out there where it looks like the virus actually affects the epithelial lining of the nose, not necessarily the nerves. And maybe this is part of why this is happening, but still trying to sort that out.
What a weird disease.
Yes, it is weird.
Thank you again, Daniel.
Oh, a pleasure.
Yeah, thanks, Daniel. Great talking to you. And thanks for everything you do.
Hey, thank you. Take care.
We had the honor of having a podcast done about our podcast this past week. How meta.
That's so meta.
It's really meta. So this is by, I'm going to pronounce it, Thalia Gigerenzer. Not bad.
Is it Thalia or Talia?
Talia, I don't know. Kathy, what is it?
Probably Talia, but I don't know either.
Actually, the Germans are pretty precise with their vowels. I would say it's Gigerenzer.
Gigerenzer? Talia Gigerenzer. Now that we've go ahead.
Butchered it completely, maybe we'll hear back from her.
Talia, who made an excellent podcast.
Yes, Talia, who made an excellent podcast. It's about 28 minutes long and just a lovely profile, very flattering profile of the show. Which
would you say it's like in the style of an NPR podcast?
Absolutely,
very
is.
much so.
You know, with her talking and quotes and a little music.
Very professional.
Yeah.
Relaxing.
A little like This American Life,
And
with
sort of a little
the
bit of
music.
fading in and fading out.
Yeah.
Okay.
Yeah, great sound quality. Just a really good job.
So Talia is a graduate student in anthropology at Princeton and called me up a few weeks ago to do this. She had originally called it, interestingly, a virus podcast goes viral, which I really liked. And now it's called Dear Virologists. In the early days of the SARS-CoV-2 pandemic, a relatively obscure virology podcast called This Week in Virology suddenly gained thousands of new listeners. Here's the story of how a quirky virus podcast went viral during the COVID-19 pandemic. Anyway, it's a great job. It's just beautiful. As I said to her, I wrote to her, thank you for being interested enough to do this, right?
Yeah, where does the motivation to do this kind of stuff come from? You know, it's unbelievable.
Well, she's an anthropologist. She's a people person.
Yeah. Okay.
Her bio here is really interesting. She says she's describes herself as a German-American writer, anthropologist, and audio producer in Princeton, New Jersey, and Berlin. And she cites numerous writings for some very reputable outlets and audio stuff, including NPR Berlin and BBC Radio 4.
Oh, wow.
Pursuing a PhD in anthropology at Princeton University, looking at friendship and intimacy among Muslim women in Delhi, India. She's got a Fulbright and had other grants as well. So this is the real deal.
Yeah.
Much more accomplished than I ever was, will be, etc.
All right. Thank you, Talia. Check it out. It's really good.
Yeah.
As soon as I got the link one night this week, I played the whole thing, and it's really good. People in the house were laughing, actually.
How dare they?
Also this week, released from the authors of Paul Has Measles, a children's book about SARS-CoV-2 and COVID-19 called Paul Stays Home. Illustrated children's book, beautiful illustrations, free download. Go up. We'll put the link in the show notes.
And really wonderful information. I was very impressed.
I have to tell you a story. So Susana Lopez, who is a friend, a virologist in Mexico, and so are Selena and Marta. Oops, I spelled her name wrong. I got to fix that in the blog post. So she sent me the English version to correct, make it Englishized. And there was a little error. I asked her to fix, but I guess, I don't know. She wrote back and she said, "You don't have to be so angry." Okay. But
even
then
she noticed it.
But even 5 minutes before I even responded, 5 minutes later, she said, "Maybe you're just grumpy."
Maybe.
And said, "I'm sorry. Yes, I am grumpy these days." But and she fixed it. She fixed the issue that
How cool
I had with it. But they already made the illustrations. It involved taking out 2 pages of illustrations, which I understand. I said, "I really don't want you to put this in. It doesn't send the right message," and she did it. So, but I was grumpy. So anyway, it's very cool. Kids will like it.
I'm going to read this
Check
to my
it out.
grandson.
You should. That
great.
would be cool.
Got to do it.
Yeah, and I gather there's already a Spanish version up, and if it follows the same trajectory as Paul Has Measles, there will soon be a bunch of other translations.
Interestingly enough, my grandson's being raised bilingually, so Spanish is his other language. So
Perfect.
I could read it to him in Spanish, and he might think I know how to speak Spanish, but that wouldn't be the case.
I was raised bilingually. I was raised with English and Italian.
Right.
But I stopped speaking it after about 5 years old, but it's still there. I can.
Oh, but your English is fine.
Yeah, you're right. Thank you very much. If I go to Italy, I can. If I went to Italy for a month, I would be fluent. Let's put it that way.
Yeah.
But I don't want to go to Italy for a month. Not now, anyway.
No.
Another time.
I'd pick another
time. All right, we have a few things to talk about before we get to letters. And the first is a very interesting paper that just was published in Molecular Cell. It is a multi-basic cleavage site in the spike protein of SARS-CoV-2 is essential for infection of human lung cells, by Marcus Hoffman, Hannah Klein-Weber, and Stefan Pohlmann. What does it say? Pohlmann? Pohlmann. From Göttingen. And, the title says it all, right?
Yeah.
The furin cleavage site in the spike glycoprotein of SARS-CoV-2. This is a very interesting site. It's a multi-basic, multiple arginine cleavage site, which was noted early on when the sequence was done because the closest bat virus, SARS-like virus, RATG13, does not have the furin cleavage site. And processing of the spike, as we've talked about before, requires cell proteases. And so an important question has been, is the furin site needed? And they do very nice experiments in this paper to show that it's needed for cleavage of the spike and for infectivity in human lung cells. And the approach is very interesting. They use pseudotyped vesicular stomatitis viruses where they replace the spike, the glycoprotein of VSV with the spike of SARS-CoV-2, so they don't have to do BSL-3 experiments. Right. And as I say, these particles are safe and adequately reflect coronavirus entry into target cells. Adequately. And so if you have this furin cleavage site in the SARS-CoV-2 spike, it will be cleaved in cells. The virus particles will get in. If you substitute with the site, with the analogous site from SARS, say, or from a bad virus, it's not cleaved and it doesn't get in. And interestingly, 2 out of the 4 common cold coronaviruses have this basic cleavage site. The other 2 do not. So does MERS coronavirus. So it's not unheard of to have a furin cleavage site.
Right. And it's not unheard of not to have one. So it's interesting, it's not like, oh, of course it has a furin cleavage site. So it's with the group of coronaviruses that has furin cleavage sites, and that is in fact necessary in this case.
So you need 2 cleavage events. You need the furin cleavage and TMPRSS2, which we talked about in a previous, to have 2 different proteases to cleave the spike so it's ready to fuse with membranes and be taken into cells. Now, what's interesting is also recently a paper came out that looked at another bat isolate from Yunnan province, and this was, I think, sampled in 2019. And there they find a multi-basic insertion at this cleavage site. So that's the first time it's been seen in a SARS-related coronavirus from bats. So that's very cool. It shows they're out there, and it's likely that SARS-CoV-2 arose by recombination, out there in nature and acquired this furin site.
And Yunnan province is the same location that RATG13 was isolated from?
That's correct.
Right.
That's correct. So I think they're 2 different locations, 2 different caves.
Right.
RATG13 was from an actual cave, whereas this virus is from an abandoned mine.
Are they the same bat species?
Different species.
Hmm.
Do you want to know the species?
No. I was just wondering. But given the promiscuity of coronaviruses, it would not be surprising to have it jump between different bat
I'll look
species.
it up while
So this is a newly discovered bat SARS-like virus, correct? So when I saw that, my first reaction was, okay, and now we've stopped U.S. support of the effort to identify more such viruses. This shows what that's about, what it's important for. You need to support that.
So RATG13 is from Rhinolophus affinis, and this is from different species: Rhinolophus malayanus, Hipposideros larvatus, and Rhinolophus theno.
Okay, so it's already in several other.
But they're all they're Rhinolophuses.
All the same,
genus, right?
Mm-hmm.
So Eddie Holmes said a while ago, this whole issue about the origin will be settled once we do enough wildlife sampling.
Yeah,
right.
Mm-hmm.
I'm impressed with how versatile the VSV pseudotyping is. Because SARS-CoV-2 and VSV are, they're both positive sense RNA viruses, but they're at very, very different positive sense RNA viruses, and time and again, people have swapped glycoproteins into VSV and been able to use that as an assay system for otherwise really pathogenic viruses. And I'm looking for why this must be wrong, but I can't find it because it just works too well.
Did I hear you say that VSV is a positive sense virus?
Oh, did I? Oh, I'm sorry.
Okay.
Oops.
Wrong with that. Negative sense.
He's dopey.
Yeah. Yeah. I'm going to change my dwarf allegiance. I'm dopey.
So the reason he's dopey is because I'm grumpy, obviously.
Right.
We thought before the show we should each have a. Dixon, are you sleepy?
I'm going to be sleepy. I'm going to take sleepy.
Going to be sleepy now.
Definitely take sleepy. I might be.
And also VSV for vaccines, right? Did you mention that, Rich? Vaccines?
Yeah. Well, not just now, but we've talked about it before.
Yeah.
As a vector, a vaccine vector, you mean?
Yeah.
The Ebola vaccine.
Ebola vaccine licensed and others in process. Yeah. So they say it makes you kind of have side effects, right? More so than many vaccines, but we'll see. If we have a SARS-CoV-2 VSV, I'll take it and we'll report.
Yeah.
Exactly right.
It'll probably make you grumpy.
Grumpier.
Yeah.
I'm already grumpy.
But will this protect you from being sneezy?
That's the idea.
Right. That's the idea.
Oh my gosh. You're going to just turn people away here, aren't we?
This paper has a really nice graphical abstract. It's open access, but the graphical abstract is a little bit more data driven than some. So it's got the diagrams and then it's got arrows pointing to the key pieces of data.
Yes.
I like it a lot.
Cool.
I found this morning an article in the New York Times, which I just thought is very, very moving. It's called India's Maximum City Engulfed by Coronavirus, right? Mumbai, most densely populated city. It is amazing. 20 million people is responsible for 20% of SARS-CoV-2 infections and a quarter of the deaths. Hospitals are overflowing. Police officers are exhausted. Doctors say the biggest enemy is Mumbai's density, particularly in the vast slum district. Social distancing is impossible. People live 8 to a room across miles and miles of informal settlements made of concrete blocks and topped with sheets of rusted iron. As the temperatures climb towards 100 degrees F, many can't stand to be cooped up anymore and spill into the streets. And this is basically a photo essay. This guy wandered around and wow. I mean, you think you have it tough.
Have you ever seen the movie Slumdog Millionaire?
Yes, it was filmed there.
It was filmed there, and I've actually been to Mumbai, and it's worse than that description, to be honest.
I took pictures of the New York Times and I couldn't get them transferred to my computer. I'll try again, but there's a front page above the fold photo, and then it's the middle center section of the first section A, and it's a 2-page spread. So one of those pictures is gigantic. It's really amazing photography.
Supposedly, the front page is available as a PDF every day. Did you know that?
Cool.
So that if you wanted to see that,
right,
you could. So why are you taking pictures, though, if you have the PDF?
Because I was going to send it to you guys and stick it in the show notes, and I couldn't get it transferred in time.
Okay.
It was just impressive because lately the New York Times has been using the full page of their print edition quite dramatically, I think. And this is another example of that.
They have been, yeah. All right. Kathy put in an article from Stat.
Okay. Sorry, I'm lost here. Okay. Yes, this is an opinion article that came up on the ASM daily or weekly newsletter. To put COVID-19 behind us, all Americans should be vaccinated. And so it talks about various aspects of vaccine coverage in the United States. It has an interesting graph that I'd never seen before that's evidently from the CDC. That's kind of a pie chart graph that shows for all 50 states the different levels of exemptions they have for vaccines and things. And so that was interesting.
Yeah.
I like this graph. That's cool.
Yeah.
Cool graph. Shocking.
The opinion is by Lauren Grossman, who's an emergency medicine physician.
She talks about a number of ways possibly to incent vaccination of everybody. I mean, it's mostly that we should actually require it. I mean, and apparently it is legal to require it, but everybody has various ways of opting out. I liked this. I thought this was interesting at the end. She says to add one more incentive, health insurers should require either a test result showing immunity to influenza and coronavirus or proof of vaccination in exchange for full coverage.
Yes.
I can see health insurers jumping all over that one because it's a terrific way to deny people coverage.
It's a great way to deny coverage, and it's a great way to save money if they do get the vaccine. Yeah.
Right.
It's a win-win for the insurance company.
Yeah.
So I wanted to point out a pedantic thing here. She writes, 80% or more of us need to be immune to COVID-19.
Oops.
Either because we've been infected with the virus or we've gotten the vaccine again. So I don't think you're immune to a disease. You're immune to infection by the virus. Right. All right. Yep. Would you agree?
Well, you get infected and then not get disease because you had such a low amount of virus replication.
Yeah, I know, but we don't usually say you're immune to a disease, right?
Right. And and to the point of this article talking about herd immunity, you actually do need 80% or more or depending on who you believe, 70%, 80%, to be immune from SARS-CoV-2.
Yeah, so that's true. I'm not arguing with that.
Because if you have only protective immunity and you get the virus and can act as a carrier, then you're not contributing to herd immunity.
Just pedantic, as we want to be.
But it's an important bit of pedantry.
I will never disagree with pedantry. I wanted to point out an article in the U.S. FDA website, Coronavirus Update. FDA informs the public about possible accuracy concerns with this Abbott ID Now point-of-care test. So this is the rapid PCR, right? 15 minutes. Is that correct?
Correct.
Yep.
And so they say
toaster size benchtop machine.
Right. Which costs more than a toaster, though.
Yes.
Slightly.
Yes.
Where they say, they've received 15 adverse reports where a negative is actually not really a negative. Right. And so they're reevaluating it. And they say, for now, if you get a negative, you should try another test before you say you're okay.
Right. If that's the case, I mean, since the majority of the tests, if you're testing properly, are negative,
right?
I mean, why bother?
Exactly.
Yeah.
Exactly.
They don't give any real numbers here as to, percentages, false negative, or it sounds like they just have, FDA has a reporting system.
Yeah.
Where people can send in complaints, and they've had more than a comfortable number of complaints.
They say they're sharing the information in the spirit of transparency.
Yeah, sure. Yeah. So just like those masks that everybody is wearing, those are all transparent masks, by the way, Vincent. What I'm really concerned about here is that there are some commercial laboratories offering tests. And my wife went to have a test for the antibody test, and she turned up negative. And to try to find out which test they ran, they would not list it. This was Quest Laboratories. Mm-hmm. So that's not right. They should actually say, we're using this test. It's a US FDA approved test. And, and here are the characteristics of the test. It's $130 a shot. And I'm sure they've made a lot of money on this.
Mm-hmm.
And that's not good either. That's just a ripoff.
My mom is actually either, I don't know if she got the blood draw yet, but she's supposed to get an antibody test as well. Mm-hmm. As part of a workup, and I don't know whether it's going to be an ELISA or whether it's going to be one of these quick tests or what. But the lab should be willing to disclose which test they used unless they have something to hide.
Well, they should, and especially given that there's so much discussion of this in so many places of the news.
Yes,
this is also kind of an interesting place for people to get some science education in terms of actually thinking about what the test is that they're having. If that information was out there and transparent, this could be a really great way for people to actually start thinking a little bit about the science behind what's going on.
And that is important because I think there are a lot of people right now who think of immunity as a binary thing.
Mm-hmm.
And we really need folks to get past that. You're not immune or non-immune. There are different types of it, and you can have levels of immunity, and different people are likely to have different levels of immunity, and it can fade over time. And these are all important things to remember, because if you go and you get a test and it says you have antibodies against SARS-CoV-2, or you've had a history of infection, well, what does that mean? Does that mean you're now at no risk? Mm-hmm. No. It means you probably have a history of having been infected with this virus, and we still don't exactly know what that means.
To which people will then say, well, why are we bothering?
Correct.
Because we need this information in order to get these answers.
We just want to know who's been infected, essentially.
We want to know who's been infected, and we also, in order to know how long, what level of immunity people get and how long it lasts, we need to first find the people who are immune. So this is step one. You do the tests and you say, okay, these people have tested positive for antibodies. And then if they show up later with a cough and get tested and they're SARS-CoV positive, then we can maybe say, maybe your immunity is not so robust.
Brianne, note for future Immune. Great title. Immune's not binary.
I love it. Perfect. I will remember that.
So the reason why they're getting the test is so that they can find an excuse for actually mingling again without worrying.
That's a terrible idea, though.
No kidding. No, I know this. But the people who are administering the tests never say that.
I know.
And if they did, you wouldn't get the test.
Yeah, but that this needs to be explained better.
Well, but Dixon state governors also want to get people back to work, and they want to use these tests.
Of course, but there are smart ways and dumb ways to do that. And the smart way is that you get your testing and contact tracing system up and running, and the testing should include both antibody and PCR testing.
Correct.
So you can find out who's been infected, who's currently infected.
That's right.
And that's going to help tremendously with the contact tracing.
Exactly.
Where did this come from? Where is it going? And then you can start reopening things and say, okay, well, now somebody shows up at the hospital with it. Where have you been? Who have you had contact with? We're going to call all those people, get them tested. And we're going to figure out where this cluster is, and we're going to get those people all quarantined so that we shut that back down again.
Yep.
Because the alternative is that we open everything up, and we're going to see this. I'm sure we're going to see this in Georgia and some other places. You just open everything back up, or open a bunch of things back up, and say, "Yeah, it'll be fine." And then a few weeks later, or a couple of months later, you're going to have another huge outbreak, and you have to close everything again. And if you thought
people are reluctant though to
go
out.
if you thought the economic damage was bad the first time we locked everything down, it's going to be so much worse.
Mm-hmm. Yes, it's a conundrum because the economy is trashed. People are out of work and they're not going to get their work back. Companies are going out of business. You got to do something.
You do, and that is all a huge
vaccine.
problem.
It's called a vaccine.
It's called a vaccine.
Some countries are testing everyone. Right?
Yeah.
Smaller countries.
Yes.
To test everyone. But I think contact tracing has to be part of it too.
Yeah.
We have later some email from people who don't like or like our letters from Sweden or about Sweden.
Yes.
So I noticed on the Times also today there was a map where in the headline had an article, but the headline is Sweden stayed open a deadly month shows the risks. And while Sweden has avoided Europe's worst outbreaks seen in Britain, Italy, and Spain, it has also experienced an extraordinary increase in deaths, mortality data shows, which they have the map here.
Yeah, and we'll get to that with those letters, which I think at least seem to have originated from Sweden.
Some, not all.
Okay.
Right. Yeah.
I have more, actually. They're flooding in as we speak, interestingly. We have touched a nerve.
Yes. Yeah, because we don't, I certainly haven't been keeping track of Swedish news. And when somebody wrote in to say everything's going great here, it's like, okay, glad it's working out for you. But apparently it's not quite that rosy.
No, everybody thought the same thing was true for Russia, too. And now look what happened.
They have the second most cases. Look at that.
Yeah, they're a mess.
Did you notice they're all in Moscow, though?
Well, that's where they're testing?
No, that's what it's reported from. But, most countries, they will say what cities but for Russia, they're all in Moscow.
Absolutely.
I would assume it's still a testing thing partially, too.
Yeah.
No, I think they're not reporting it from elsewhere. They're saying these are from Moscow. That's what I guess.
That's the case, then they've really got a problem because it's everywhere too, right?
Yeah, probably.
Amazing.
Kathy, you found a video? You got a video?
Yeah, this is thanks to Bert by way of Bryony because it's a BBC video and it shows how the United States lost 6 weeks. And it's got really nice graphics and timelines and they line up countries by when they first had a certain number of cases or deaths or things like that. And then they measure how long until the next thing. And then they do the same kind of thing for different states in the United States. So it's really informative and I think worth taking a look at.
Good.
Nicely done.
Should never happen again.
Until the next time.
Right.
Yeah, right. Unfortunately, there's a short memory, but folks, be outraged, complain.
Yeah.
Make sure it doesn't happen again. This shouldn't happen.
Grumpy.
Like us. Look at where it gets us.
Come on, let's get grumpy.
See, we have a reason to be grumpy.
Yeah.
That's right.
All right, Kathy, why don't you take that first one?
Sure. This is someone who wrote directly to me. David writes, Dear Kathy et al., am I correct in learning from the podcast that once a vector that itself can induce an immune response is employed, its use a second time could be a problem? I've heard the program a number of times. I listen to it on my daily 3-mile walks. be safe, David. And so this relates to the podcast that we just did and on Wednesday and was released yesterday. So that's 613, where we talked about this chimpanzee adenovirus vector. And we talked about the fact that using a chimpanzee adenovirus could avoid the problem that a lot of people are going to have immunity already to human adenovirus vectors. So that would circumvent that. But once you've given this chimpanzee adenovirus vector, you're going to give a huge bolus of virus particles. And so you're going to get immunity to the capsid proteins of that chimpanzee adenovirus vector. And then if you came in with a boost for that same antigen in that chimpanzee vector, or that chimpanzee vector, as Rich described, for some other antigen that you might want to use, it could be a problem because you'll have all the antibodies that have been directed against that first chimpanzee adenovirus, and it will clear that virus. And so your new input vaccine won't be able to, it'll get cleared, and so it won't have time to express its antigen and give you a good immune response.
Now, it seems like if you're using it as a booster for the first vaccine, that's not necessarily a problem, because that would be the case for every type of booster shot, right?
Yeah, but it's why let's let Brianne talk.
I think that there are two issues there. If you were using the chimpanzee adenovirus, I'm sort of making these numbers up, but we'll say that there were 100 responses, 100 epitopes that could be responded to in the chimp adeno, and 1 from SARS-CoV-2. And so you're probably not going to boost that 1 really well before the 100 from the other vector start to make a response.
Whereas if you were boosting with something like an inactivated virus vaccine, all the antigens would be from the virus you wanted to boost against.
Exactly. So it's a small proportion, and you also have to think a little bit about the fact that some of those parts of the vector that you're using might induce particularly strong immune responses that might sort of be overwhelming.
Mm-hmm.
In the end, I think from the experience out there so far, which isn't much, but people are concerned about this and they do appropriate experiments. I think it's going to turn out that not all vectors are the same.
Yes.
In some cases, and there will be a robust immune response to the vector, and it limits its utility over time. And in other cases, it's not going to be as big a problem, and it's just case by case.
A huge part of some of the projects in my PhD lab, where people were comparing all sorts of different types of adenovirus, including the chimp adenovirus, to look at how much immunity. And there was a huge amount of variation from type to type.
Okay. And this seems like intuitively something that might be a little less of a problem with a pseudotyped enveloped virus than it would be with an unenveloped virus, wouldn't it? Like, couldn't you kind of make sure that the envelope is coded primarily in what you're trying to induce immunity to?
You might be. I guess I hadn't thought about it that way before. I think you might be able to do that. Makes sense to me.
But it could be a problem with any kind of an engineered approach.
Sure.
Obviously, in some vaccines, you do boost and it works and it's okay. So it really depends.
Right. And again, with an inactivated vaccine or something like that, where the entire thing is the thing you want to induce immunity against, it doesn't matter if it picks one antigen or another. It's all going to be against the right thing.
Yeah.
Right. Exactly.
So these HIV trials where they do prime boost, they use different vectors for that reason.
Right.
Yes, exactly. Okay. That's exactly
right. I'm always reminded of the Botox industry telling you that this lasts for about 3 months. If you try it again, you've got an antibody against the Botox and you won't get any effect whatsoever.
Oh.
Because it eliminates the effect before you actually get a chance to have the toxin work.
Oh my God, you could save money on canned food after that.
That's right. I never thought of that.
Dixon, you found this out by experience.
Exactly. That's why I do a lot of sleeping now, because I
got it.
Because your Botox wore off.
Alan, can you take the next email?
Okay. Let's see. So this is Hi or Jai? Jai. Dear Twivers, it says, I'm sure you've seen this reported, and I'm wondering if you could comment on this study, the airborne lifetime of small speech droplets and their potential importance in SARS-CoV-2 transmission, as reported in the Washington Post, and gives the link to the original paper in PNAS and the Washington Post article. And I did not get a chance to read this paper, but I think the general idea, it's another one of these looking at speech droplet type of
when you talk,
it's actually an
droplets.
it's actually an interesting paper, because apparently I just skimmed it, but they've got an experimental setup that looks like they've got a GFP expressing influenza, and they've got some sort of a chamber where they can aerosolize virus and treat it as an aerosol. If they, I'm thinking of another. I'm sorry. Thinking of another
right.
paper.
Okay. No, I'm thinking
of the UV paper.
Right. This one is just droplets, light scattering of droplets, right. And they have somebody repeatedly say the phrase "stay healthy" in a loud voice.
And the TH is apparently a real problem.
Yeah. Okay.
Wow.
And they're able to view the droplet distribution there and see that they stay airborne for a considerable time.
Yeah, there was a group from Belgium that had a paper out on that too, wasn't there? Some time ago.
Don't know.
Remember about the bicycles? The bicycles.
These tiny droplets that you make a whole range of sizes, right? But
sure.
The tiny ones go a long way. They're very small, and we don't believe most of the time they are transmitting SARS-CoV-2.
To me, the most interesting thing to think about that we brought up some time ago is if you're out on a cold morning and you're talking or breathing and you can see your breath.
Right.
Okay. That's a wonderful demonstration of just aerosolization of what's in your respiratory system under normal circumstances.
Yeah. Brianne, can you take Peter's?
Of course. Peter writes, "Hello, Vincent. Toward the end of TWiV 613, you looked for a famous quote addressing what we know, think we know, and don't know. Rich found his Socrates quote, but the first that occurred to me is from Bertrand Russell, which is along similar lines. I've had to look it up to quote accurately. The whole problem with the world is that fools and fanatics are always so certain of themselves, and wiser people so full of doubts." From Peter.
Wonderful. It's just great.
There's one from Charles Darwin. It was in a slightly different angle, but the initial part of it is relevant. Ignorance more frequently begets confidence than does knowledge.
These are nice summaries of the Dunning-Kruger effect,
yes.
Which we've talked about before. The incompetent people are so incompetent they don't know how incompetent.
The less you know how little you know. Yeah.
Yeah.
Dopey. Okay, I'll be dopey.
Rich, can you take the next one?
Maureen writes, "The meatpacking plant outbreak you discussed this week took place in South Dakota, not North Dakota. Not all flyover states are the same." Right. Writing from Montana, where we have a Democratic governor who has some common sense. Stay well. Okay. We stand corrected. Thank you very much.
Is anyone flying over these days?
Yeah.
I'm not going anymore.
I wish I was on my way to Montana.
Dixon, can you take the next one?
I can. Vinny writes, "No, your eyes are not deceiving you, Dr. Racaniello, and I have the exact same names." He may remember me as I wrote to him in the past. Needless to say, I'm an avid listener these days. I heard the expert panel state that all viruses mutate and that SARS-CoV-2, like all viruses, has mutated but not into something more virulent. I've also heard the panel comment on how everyone and their mother is writing papers to get noticed. Can you comment on this study as reported by NBC News? And then he lists a couple of sites that you can check to see what's going on. I didn't check them, unfortunately.
You don't have to, Dixon.
So thank you, Vincent Racaniello, for drawing this to your attention.
Yes. That's right.
This is actually from Vincent Racaniello, who exists. There are actually several. This study we've talked about, so we don't need to.
I actually have a disambiguation page on my website for all the Alan Doves.
So how many stimulus checks did you get, Vincent?
I didn't get any.
Then he got them all.
Maybe that's fine. He wrote to me years ago because he sent a paper letter, and that was the error. And so now he's found me again. He lives upstate, and he has another one coming, which we'll put because he talks about the history of all the Vincent Racaniellos he knows.
Oh, good! I want to hear that.
Nice.
Wow,
it's very, very
Kevin Bacon story.
Yes,
funny. Okay, Talia. Oh, look, I get Talia.
Great.
Just a comment on his link. We've talked about this before. This paper before. It's the one that says this mutation that's shown up affects transmission, and we debunked it completely.
The data do not
the one
show
that
any
says
such
that
thing.
it's alarming.
Yeah,
you can ignore it.
Normally, I wouldn't have read this, but since it's from Vincent Racaniello, who calls himself Vinny,
right?
Yeah, really.
I still have his original letter.
He could be your cousin, Vinny.
So funny. So he was working for Columbia, and he was a lawyer, I think, and doing some consulting, and he saw my name. So who's this? And he wrote to me.
Huh.
But the thing that's funny is, a few weeks ago, I got a letter from a different Vincent Racaniello
Oh,
at Brookhaven, who works at Brookhaven, who I've known has been there for years. And these people are all related to me. They have to be.
They do.
Yeah.
Sure.
And the next letter is going to explore that a bit. So we'll do it then. Anyway, Talia writes, I'm a PhD student in anthropology at Princeton. We know that already.
Yeah.
Yes.
Your question, how different is COVID-19 SARS-CoV-2 from other viruses? What viruses should we be comparing it to? When we first became aware of HIV, no one thought that it resulted in a long-term condition. Not really correct, but we'll fix that. Should we be asking if COVID-19 could result in a longer-term condition too? I guess the most obvious comparison is SARS-1, which makes a lot of sense, but that's the only comparison I've heard people make. Maybe we should be talking about more what viruses it's comparable to, because that will shape the questions we ask. All the best from Princeton, where the squirrels now outnumber the students. And I bet they're mostly gray.
Yes.
Mm-hmm. I think they are.
We have a lot of gray squirrels there on campus. So when HIV emerged and it was discovered to be a lentivirus, there were a whole slew of lentiviruses that had been studied, of horses and goats and cats that were known to cause immunosuppression, right, Brianne?
Yes, that is correct.
So I don't think we doubted that it might cause a long-term condition, right?
No, I don't think we doubted that at all. And this goes back to something from very early TWiVs about the fact that, when we realized it was a retrovirus and that it inserted its genome into the cell, that gave it the ability to be a longer term infection than you might see with other virus types. So it goes back to the 7 genome types.
Right.
Most in my that's why I ask you that all the time, Dixon. There's a method for my madness.
The moment I give you the answer 6, you've got a problem. I don't, because I don't know myself anymore.
If the most informative, Talia, is to compare it to similar viruses, and mostly within the same family, but sometimes broader. But, SARS-CoV-2 is a coronaviridae, which is part of a larger, an order, I guess, collection of families. But SARS-CoV-2, as Ralph Barrick said on the first time we had him on, and by the way, he's coming back in a few weeks.
Good.
To talk about his cool mouse model for SARS-CoV-2 infection. He said this is SARS-like disease, right? I mean, now we know there are differences, but remember, there are only 8,000 cases of SARS-1. And here we have millions, and that's why we see all the fringe stuff, like COVID toes and thrombosis and Kawasaki-like disease.
Yep.
Differences. But the bottom line is acute respiratory distress and acute lung injury, which we do not see with most strains, say, of influenza virus, except for the avian viruses that sometimes jump into people. So what were you going to say, Brianne? Go ahead.
I was going to say that, so this virus is part of a group of viruses called coronaviruses, and there aren't too many that sort of lay people have heard of that you might compare to. There are some that cause the common cold and SARS and MERS. There are a lot of coronaviruses we've found, but you might not think about them as often. And someone actually asked me earlier this week, what % of viruses did I think we had discovered?
Versus how many there really are?
Yeah. And my answer was very small.
Very small. Good answer. Good answer.
Yeah, it's a good answer.
And so it's possible that there are lots of viruses like this, and there are lots that we could compare it to, but we haven't described them yet.
So this reminds me, these common cold coronaviruses, the 4 human ones, they have funny names like 229E and HKU, blah, blah, blah. And OC, he remembers as old cow.
Old cow. That's good.
OC something. Kathy, can you take the next one, please?
Sure. Mike writes, Dear Professor Acaniello, I did a brief stint as a molecular virologist in Alan Campbell's lab at Stanford. Now I am a pediatrician, but for probably more than half of any given day at work, I'm working with viral diseases. So that prior experience is relevant to my career. Anyway, I was listening to your episode 613, and one of your crew expressed some skepticism that Jenner's cowhide was still preserved. In fact, it is, and I have seen it with my own 2 eyes when I was a 4th-year medical student doing an international infectious diseases rotation at St. George's Hospital in South London back in 2005. There is a framed cowhide. It was in a stairwell, of all places, with a plaque next to it that explains that this is the cowhide that Jenner used. Now, obviously, I can't prove that it is the genuine article, but there is a cowhide with multiple pox-like lesions that appears to have been tanned and preserved in that stairwell, in that hospital, and they are all very proud of it.
Excellent.
So there you are.
I was the skeptic. I have no doubts, and I appreciate this. Even fewer doubts now that this actually exists. I was seeking validation somehow. That it is the cowhide that Jenner had used. I'm just a little incredulous at that they were so impressed with the experiment that they preserved the cow at the time.
Mm-hmm.
Okay. But maybe so. Actually, it was a pretty amazing experiment.
Yeah,
they probably realized how cool it was at the time and said, "We got to save this hide."
Tanning leather is a very well worked out process. So it probably wasn't a big deal to get the hide saved.
No.
Yeah, I have actually seen the Phineas Gage skull and the tamping iron in a similar kind of stairwell situation, and I always felt the same way. I was like, "Really? You thought then to save all of this?"
Right.
By the way, as I was looking for validation, I went searching on the internet and I found that there is somewhere else, I think in London, that claims to have one of Blossom's horns.
Oh.
Parts are everywhere.
Yeah.
All right, so that leads to the question. What other medical artifacts do we have like this? Virus specific, say?
Well, there Louis Pasteur's flasks are still
that's true.
Somewhere,
just
right?
a moment. When I was at Rockefeller as a postdoc, I got to see Shope's original slide of the tumor from the chicken.
Yeah.
Oh, yeah.
Cool. Did you find the feathers of the chicken?
That's a silly question, Vincent.
Why?
Because you don't usually take sections of the feather and put it on a slide.
No, I'm not talking about a slide. I'm talking about feathers, Dixon, like the hide of a cow, the feathers of the chicken. Would you rather I said hide of the chicken?
Maybe.
Dixon.
No. Alan
you
followed it with the flask of Pasteur. What's that got to do with the hide of a chicken?
I said a medicinal artifact, that's all.
right.
Boy, you're prickly today, Dixon.
No.
Alan, you're next.
Go ahead.
Okay. David writes, Twivers in regard to TWiV 611 and wet finger dentistry. When I was a teenager around 1980, my orthodontist not only didn't use gloves, but didn't use soap or any disinfectant when he washed his hands. I commented on this unhygienic practice once, and he said, "No, I just rinse with water." I was amazed and disgusted. It's no wonder I got sick as often as I did back then.
Wow. Wet finger
Wet finger dentistry.
Brianne.
Rodrigo writes, Dear Vincent and crew, thank you so much for all you do. I listen to and learn from every minute of your podcast. You guys are truly terrific. On the topic of far UVC light, it seems like you may have it backwards with regards to its safety. this peer-reviewed paper published in Nature. And this is about, from a couple episodes ago, the idea of using far UVC light to damage viruses and not that it wouldn't damage people. And so this paper states, due to its strong absorbance in biological materials, far UVC light does not have sufficient range to penetrate through even the outer layer on the surface of human skin, nor the outer tear layer on the outer surface of the eye, neither of which contain living cells. However, because bacteria and viruses are typically of micron or smaller dimensions, far UVC light can still efficiently traverse and inactivate them. However, as discussed above, based on biophysical considerations and in contrast to the known human health safety issues associated with conventional germicidal 254 nanometer broad spectrum UVC light, far UVC light does not appear to be cytotoxic to exposed human cells in tissue in vitro or in vivo.
I think we got it forward.
No, we said it was bad.
No. Broad spectrum UVC light is bad.
Yes.
Far UVC is okay.
Far UVC, right? From what we were just hearing about it for the first time on that episode, and my initial reaction was, "Whoa, don't hit things with UVC." But then, as I looked at the data and the information on it, I at least came around to the view that okay, this far UVC is a very specific way at the far end of the UV band, and that does look safe, but. Wanted to discourage people from going out and buying the conventional UVC lights that you can find that are definitely not safe.
Yeah, I think that when I read it, as a person who gets a sunburn when I think about the sun very hard,
right.
I wanted a little more information before going any further with it, but I think this is really helpful. So thank you, Rodrigo.
Yes.
This is the paper that I was thinking about before, where he's actually developed a machine where he can irradiate aerosolized virus of different sizes and then collect it and test it for infectivity on monolayers. So it's a really interesting setup. He's even got a little diagram of the machine that he uses and a picture of the apparatus. So
cool.
It's an interesting paper.
Rich, you're next.
Let's see. Felix writes, okay, good. Okay, now regarding online chorus, this is for Kathy and Rich. After doing a lot of research and testing various video alternatives to Zoom, like Jitsi and audio-only platforms like Discord, we've settled on Mumble. You can work with just audio and forfeit video. Mumble is definitely the best solution. Free advantages are 1, free software, 2, very, very efficient, 3, noise reduction. The main disadvantage is that since the project is not a service, you need to find a host, and gives a link to where we can possibly find a host. So I'm interested in this. Thank you very much. The biggest issue with trying to do some sort of chorus activity online is latency. Okay.
And that is, just to jump in here, Mumble is developed specifically for the online multiplayer gaming community. And they are exquisitely sensitive to latency. So I think that is probably why this is favored then for choral practice, because I'm sure that low latency, I have not tried Mumble myself, but I've heard from a number of people that it's the best for a low latency connection among multiple people on audio.
And my question is then, everybody would be able to hear everybody else at the same time?
Yes, that's my understanding, is that you can do a party line group channel.
Okay.
It's got to be, for singing, it's got to be like 0.
Yeah,
okay.
And this is used for people who are teaming up to play World of Warcraft or Fortnite or whatever to talk to each other as a team, and they want to be able to say things before the bullet hits. Kind of stuff.
Well, we'll give it a rip.
Yep. Okay. We actually had a few emails about choruses. The next one, which is Dixon.
Siobhan writes, "Hi,
Siobhan.
Siobhan writes." Okay, Siobhan writes, "Hi, TWiV team. I first stumbled upon your podcast last year while preparing for Journal Club, episode 348, Chicken Shift. waded heavily into my interpretation of some papers about Marek's disease virus and the evolution of pathogenicity as the result of leaky vaccines. I've been singing in choruses since I was in elementary school. Now I'm halfway through a master's in virology and still sing in a chorus every week. It's been one of the biggest things keeping me going when my MDV BAC clones don't turn out right. The simultaneous cessation of research activities and choir rehearsals has been devastating. Anyway, it was great to hear you mention Phoenix Chamber Choirs for the longest time in today's episode. Many of my friends are in that choir. They're tickled that A, I listen to 2-hour virology podcasts for fun, and B, the people who make the podcast watch their video. I've convinced them to give TWiV a listen since you've watched their video, and I listen to it too. It is fantastic.
Yeah, it's really great.
Excellent.
Oh, I'm looking forward to listening to it.
Yeah, this is from Vancouver, British Columbia, even though Phoenix is in their name. Don't let that throw you.
They have a percussion section with somebody with a disinfectant wipe thing going on and on.
Yeah.
All right, there you go. Two choir people, just like Rich and Kathy. Torquato writes, the Spanish government has just announced the initial preliminary results of its COVID-19 serologic survey for SARS-CoV-2. It's based on random representative sample of over 60,000 people selected by the Instituto Nacional de Estadística, akin to the U.S. Census Bureau. Rigorous stuff. Formal publication expected soon, but here are the highlights. Sorry, without confidence intervals. Overall IgG prevalence, 5% nationally. Significant variation across provinces, 1.6 to 14.2%. Among people who reported experiencing anosmia at some point in the previous 2 months, IgG prevalence is 42%.
Wow.
That's loss of sense of smell.
That's amazing.
Wow.
That's coming across as a really critical symptom.
I mean, those people were asymptomatic infections?
No, he didn't say that. He just said they reported.
Right. So just to interpret this correctly, it does not mean that most of the people who developed COVID-19 had anosmia. It means most of the people who had anosmia had IgG for SARS-CoV-2. Right. So in other words, this is a strong diagnostic symptom if someone develops it, but not developing it doesn't mean you didn't get the virus.
Right.
So last night, I asked Daniel, do people get anosmia without respiratory symptoms? And he said, absolutely. People say, I can't smell, and they come in and there are no other symptoms and they're positive. So it can happen in the absence of. Interesting. The infection mortality rate was not specified, but here's my back of the envelope calculation. Given that the population is 47 million, about 2.35 million are estimated IgG positive. PCR confirmed deaths stand at 27,100 as of 5/13, but there is unaccounted for excess mortality, 6,000 as of 4/28. So the actual number could be as high as 33,000. If we are not too fuzzy, this gives a rate between 1.15% and 1.4%. And that's your infection mortality rate, Rich.
That's a scary number.
Yes, it is.
That is.
If that's true, that's a scary number.
That is pretty consistent with other figures that people have been kind of converging on, I think.
If it's 1% and we need 80% of people infective before this slows down, that's like 3 million deaths in the U.S.
Yeah.
And you give some links to these things in Spanish and the Times article. Thank you, Torquato. Let me take the next one since it's very brief and it's my fault. Brian writes, article reference concerning 80,000 deaths. Stat is from 9/2018. It was not about 2019. Whoopsie. Okay, sorry. You're right. And but the point still is 80,000 deaths. We had a flu vaccine. This year, the range is 24,000 to 62,000. 43% of U.S. do not take flu vaccine. I wonder how that would impact the numbers if they did. So this is the danger of looking at an article. What was the stat article I was looking at the other day? I can't remember. And then at the bottom, they give you things that you might be interested in. And one of them was the CDC numbers. And I mistakenly thought it was for this year, but it's not. Got to be careful online. Yep. Alan, Kathy, you are next.
Okay. Philip writes, Dear TWiV, I've been listening admittedly off and on since around 2014, and I remain enamored of Threading the Needle. That was our episode for TWiV 200. I work in a grocery store, and I have a question that will probably make me seem like an idiot. I've often wondered in the past couple months whether there's real value in elbow bumps, a practice I avoid, or more generally, using an elbow to open a door or perform other typically manual tasks to the extent it's possible when I can't immediately wash my hands. I'm specifically wondering whether, after initial physical contact with the surface of the elbow, a virus will travel around on the skin, but it's just not likely it will make it all the way to a person's hands or face. Essentially, once on a surface, how does a virus spread across that surface? Thank you. Please continue to be grumpy, Philip.
He doesn't have a choice.
So how does a virus travel around on the skin? I think not very well.
Yeah, I would say it doesn't.
No. Yeah, it's more of if it comes in contact with your hand touching your skin, then that will transfer it onto the new surface of your hand. It's not going to move on its own across your skin.
Right. No. Right.
Right. It's not a silly question, but it is. It's worth remembering that we touch our faces and skin and other parts of our skin a lot more frequently than we realize.
And I personally do not use my elbows to touch my face.
I do not.
No. However, do you ever touch your elbows?
Never.
With your fingers?
No, I stay away from
touching mine right now.
Yeah. So if you hit something with your elbow and then you hit it a little too hard and ow, I grabbed my elbow because that hurt. Or for some other reason you scratch your elbow or something, you can spread something around that way. I really don't think this would be a major means of getting SARS-CoV-2. I don't think that's going to be the main story, but it's not silly to worry about what's touched.
Yeah, as a matter of fact,
really nice.
Yeah, I think a lot of this, the hygiene and transferring virus is common sense. And so if you have a mindset of thinking, where could the virus be? How could I pick it up? How could I transfer it? That's an important mindset.
And there's this thing that I don't know if this happens to everybody, but when I started working in a lab, I kind of developed this intuitive sense that my hands are not clean now. Mm-hmm. And it's because I was working with something that's not clean. And now I'm going to remember not to touch anything that I don't want dirty hands on, like my face, until I've had a chance to wash my hands.
Yeah.
So I think a lot of people are hopefully developing this same type of habit of, I stopped to fill up my car and I had my hand on the gas pump. I'm going to treat that as an unclean surface. Mm-hmm. And I'm not going to touch my face or anything with that hand or eat with that hand until I've washed it.
Yeah, exactly. I think that's a sense that a lot of us get of the where have your hands been when you're working in a lab. And, Philip, I don't think it makes you seem like an idiot. I think it makes you seem like someone who's actually thinking about some really important things that I wish more people would be thinking about.
Mm-hmm. Yes. Yeah, just go shopping in the grocery store and you'll see.
Oh, well, I'm sure he does.
6 feet away from, they don't know what 6 feet is if you drew them a picture.
So you can't do elbow bumps now because you wouldn't be 6 feet away.
That's right. Unless you're plastic, man.
Can you take the next one, please?
Sure. Mark writes, was looking at the inner tubes this PM and saw this PopSci article on how vaccine disinformation spreads through social media. Discusses the work of an old collaborator of mine, Neil Johnson. The paper is behind the Nature paywall, always a pesky problem when you no longer work in academia, but a new draft is up on Archive. This is the kind of work that gets Neil in trouble. And the Nature paper actually does not seem to be paywalled. Maybe I'm wondering if maybe they opened it.
Could be. It's not paywalled to me, or at least the Ars Technica article isn't.
No, the Nature article isn't either.
This is something, this research is getting coverage, and I'm glad. because this study looked at vaccine misinformation spreading on platforms like Facebook, notoriously, but elsewhere too, I think. And it turns out that there's a lot of it, and it's interconnected, and it's not looking so good if you want to have relevant facts about vaccines getting promoted. Of course, from Facebook's perspective, this is great because it's interactive and people are looking at those pages and you can put ads on them, so it's all fine. Which is a big part of the problem with the whole Facebook business model. But yeah, there's a lot of misinformation and disinformation out there, and these sites are well connected to each other, and they're spreading this and looking at a situation where we're going to need vaccines to pretty much save the world. This is not a good way to go into it. I like the
first sentence in the abstract with all of its citations.
Yes.
Distrust in scientific expertise, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14 is dangerous.
14 is dangerous.
Great. Love it.
Yes.
It's really good. Both articles are very good. Really well done. This online ecology of vaccine views where they trace, the ecology of undecided anti-vax and pro-vax views globally. It's remarkable. Remarkable. Thank you so much. It's great. Mm-hmm. And then the older article, which is on Archive, Hate Multiverse Spreads Malicious Content, COVID-19 Content Online Beyond Individual Platform Control. Really interesting stuff. Thank you very much. Brianne.
Sure. Larry writes, TWiV heroes. We, including uninformed lawyers like me, are so lucky that you folks continue giving your time to do this. I'm sure you're not uninformed, Larry. In a recent episode, Dr. Griffin mentioned that because viral load decreases, many patients are PCR negative at the height of their illness toward the end of the second week, in the middle of the famed cytokine storm. On the other hand, with regard to the Korean reinfection study, also mentioned recently, you noted that the supposed reinfected had likely not been reinfected, but instead had high enough remaining virus RNA well post-illness to trigger a positive result. How do you square these two? Is it that the Korean threshold cycle number was significantly higher? Thanks so much for all you do. I think that's a really interesting question, Larry, and I haven't looked at the raw data, but I think that the idea that people were being counted as positive with a relatively high threshold cycle, so there was a relatively low amount of RNA, makes sense to me.
Yeah. Yeah, we don't have the Korean reinfection quote study out. It's just a newspaper report, but that makes perfect sense, Larry. You're thinking like a lawyer.
I'm very impressed. Larry, you say you're uninformed, and yet you correctly talk about threshold cycle here.
Yeah.
Right.
I think that's pretty informed.
Yeah.
Rich Condit, you're next.
How do I pronounce this? Chirag?
Chirag?
Right. There may be a way of making challenge trials safer. So this is the idea of using a vaccine and then actually deliberately infecting people with a virus, which we've to see if they're immune or resistant, which we've said is a dangerous idea. Looking into the different vaccines being developed for SARS-CoV-2 coronavirus, there is only one group working on attenuating the virus itself. From what I've read, attenuating a virus can take a long time, so this might not even be relevant. However, if we don't have a vaccine yet and the group successfully attenuated the virus and it passed phase 1, could that attenuated virus be used to test itself and other vaccines? This has a familiar ring to it.
Yeah, that's what they do for flu challenges. They use a vaccine strain that's not that virulent, right?
Mm-hmm.
This is done for polio trials recently where they're trying to make a new OPV. So it can be done with a vaccine strain.
In fact, I've heard of people who wanted to make a replacement smallpox vaccine who've talked about whether they could challenge with vaccinia.
Mm-hmm. So that makes sense.
Yeah, that's good.
Yeah, and And just another follow-up on this same subject, because this is something we talked about a few weeks ago, where there's a bill in Congress. I don't know what the current status of it is, but the bill would have allowed the FDA to approve challenge trials. And my assessment of that was that they were doing this not because the sponsors of the bill thought that we should have challenge trials, but because they wanted the FDA to have the flexibility to approve them if and when it became safe to do them. And, you could imagine, in addition to this scenario, you could imagine a scenario a few months from now where we have a treatment regimen that actually works, and maybe we can get to a point where, you need to go to the hospital, but then we're going to put you on this cocktail of drugs, and we can reliably say that that's going to keep people alive. Under those circumstances, and given the urgency of the problem, it might become ethical to do a challenge trial. So there are scenarios you can come up with where it might make sense, and Congress is just making that, the FDA's call. And I've subsequently heard from a source at the FDA who didn't want to be named, but who said, yeah, that's in fact exactly what's going on, and that the folks at the FDA are having exactly those kinds of discussions.
If you had a therapeutic that would 100% protect, as you say, what the hell do you have to rush a vaccine forward?
So that you don't have to get people to the hospital every time they get
you may
sick.
have an antiviral that doesn't require that. Right?
No, I'm just hypothesizing ways that you could.
I just think it's a bad idea. And the Oxford trial we talked about the other day is going forward with a standard at-risk thing, and it's going to be informative, right? So,
yes,
just don't buy it.
No, I think it's a trick the FDA should have in the bag if they decide it makes sense.
I just want to comment on the fact that Chirag says, I'm not in any field related to viruses or immunology or even biology. And yet Chirag came up with this
great.
Using an attenuated virus for a challenge.
Good idea.
Yep.
Good idea. However, in the case of the SARS-CoV-2, I don't know if passing phase 1 would be sufficient, maybe. But, that's interesting. He says there is one, and that's correct. There's a group in China that is making an attenuated virus by recoding the genome, which shouldn't be that long, actually. You should just synthesize it and do your tests. Anyway, very cool. Dixon, you're next.
Nate writes, Dear TWiV, regardless of what choice the US FDA and others in this country make on the ethics of vaccine challenge trials on volunteers, are other countries making the same call? What happens if a vaccine is developed elsewhere using volunteers, or worse, coerced or uninformed participants, say Uyghur prisoners, for example? Is that a possibility? Would or should we refuse to use the vaccine if that happens? Would love to hear you discuss this. Thanks, Nate.
That would be awful.
Yeah, that's
sure would be.
So the question is, would we license such a vaccine?
Well, the first question is, would we know?
Yeah.
And then the second question is, would we go along with those data? And for some drugs to be licensed in the U.S., they have to be tested in the U.S., right? Because the population can make a difference. I don't know if that is the same for vaccines. Probably not, right? I don't think that's going to be the case here.
Because, the Sabin vaccines were tested in Russia and then licensed immediately in the U.S.
By the way, there's a new book out on that, I think.
On what?
On the development of the polio vaccine. I just heard something on the NPR this afternoon on the radio while I was eating lunch that somebody's written a book about it now. Another book about it. How's that?
Okay. Yeah, there are many. Good question. I don't know the things. This is a little out of our wheelhouse, but if anyone knows, let us know.
I hope that you can see, Nate, that we all feel somewhat uncomfortable at this moment.
Right.
We do.
Yes. This is not something that I would like to see. And I would really not like to have a vaccine like that come to market in the U.S.
It just encourages future similar things, right? Yeah.
Yeah.
Mark writes, I have to read this intro. I'd like to acknowledge the greater TWiViverse's membership in the exalted firmament of the professoriate before I begin referring to you in the vernacular.
Lord. What do you say?
You're making fun of us?
No.
You're making fun of us?
No.
You don't think so?
No.
You can be sure?
Yeah.
I'm not so sure. Because he may...
I do not occupy that exalted firm.
You frequently refer to various statistical models used for epidemiology, surveillance, and prediction. Rich, in particular, seems somewhat enamored of the IHME models. The statistics and biostatistics folks at UW, University of Wisconsin, are significantly less sanguine and provides a link, giving models and modelers a bad name. I'm a humble and soft condensed matter physicist. But I can
At
tell
least
you.
he didn't say just.
Wait,
Yes, indeed.
Right.
a humble, soft, condensed matter physicist.
No, is he soft, or is it soft condensed matter?
It's
It's soft
Okay,
condensed matter.
right. That's what I
physics
wanted to
is the
make sure
field.
we got.
He's humble.
Right.
Yeah, that I got.
He's humble.
Okay.
The condensed matter is
All
soft.
right, I can
He's
tell
a
you these
physicist.
econometric models are essentially a bunch of crap.
That's a good scientific way of
But
saying
what do
it.
you like about it?
Speak up, express yourself here.
You don't really want economists making your pandemic forecasting models. I mean, curve fitting of the second derivative of time on a log scale. Sheesh. And that Stanford prevalence study, don't get me started on that. That's great. So, Vincent, I'd like to suggest you invite the director of the Center for Applied Statistics at Columbia and Columbia professor Andrew Gelman to the program. He and his group have provided excellent critiques in his blog of many of the models being released as preprints. And here's one's fatal flaws in Stanford study of coronavirus prevalence. Finally, an appropriate quote about the IHME model. I'd always imagined that if we fell to pieces, it would be because we did something clever, but deeply unwise. It is very depressing to realize that we may well end ourselves through sheer incompetence. Oh my gosh, this is about the IHME model. Love TWiV and really enjoyed Vincent's virology course, especially the pop quiz polls, which demonstrate that while I may be 3 times older than the typical Columbia College undergrad, I remain 3% smarter.
By a factor of what? What is the standard deviation on that?
This is great. Rich, any comments on IHME models?
No. So, it's the I guess the most prominent model. It's the only model I'm aware of out there that tries to do what it does. I don't know that it's by economists necessarily. I don't know what the background of the people doing it is. They apparently have some experience in modeling stuff to try and forecast what hospitals need. But of course, this is the actual modeling itself, and the statistics is way out of my wheelhouse. I've trusted these guys. Okay. And if they are untrustworthy, I need to hear about it. Okay. So the idea of having somebody on the show who can speak intelligently to the models is a good idea.
I would love to hear from Andrew Gelman, as Mark points out. And also, Mark, I would agree with you about the Stanford study that you mentioned.
Mm-hmm.
Oh, yeah.
So we had Jeff Shaman on, who does models, and we didn't ask him anything about models, Rich.
No.
Because we don't know what to ask. What are we going to say? Does this model work? We're just going to say yes.
Of course it does. So I want to ask Mark a question. I want to know if he gets hard data on soft material.
Yeah.
Anyways. So I think the question is, how does this model?
How
what are
would
the
be
pros
fine.
and cons of this model?
Well, he could say anything, and I wouldn't know, but that's fine. We can get somebody.
Right.
By the way, after having read the email, I agree that he was not insulting us in the first sentence. That's how he talks.
We do preface most discussions on models with the quote that all models are wrong, but some are useful. Okay.
Well, probably
For
Mark
whatever-
doesn't agree
for
with that
whatever.
entirely, but I'll bet Professor Gelman doesn't agree with that. I'll try and get him on the show. Sure.
Yeah.
All right. Now we have a bunch of letters about Sweden.
Yeah, so these are a couple of long, detailed letters about Sweden that will be posted on the website. And Kathy wants to read excerpts, but I think we can do just some.
I wasn't the only
summary
one who wanted to
points,
read
if I may.
excerpts.
Yes,
I
yes.
was quoting someone who uses black ink in the document.
Yeah, that's me. That's me.
Okay.
No, I think we should I think it gives the flavor of the.
So the main points that I see here are. First and foremost, that there are different opinions about the success of Sweden's approach to the COVID-19 pandemic, and we got a letter from somebody in Sweden who was saying basically that things are going well, And we didn't really know how to react to that because I don't have inside information. But now, apparently, we do. There are folks who are pointing out that there are things may not be so great there. First of all, death rates in Sweden are much, much higher than in neighboring countries. The ICUs in some parts of Sweden, at least, are indeed getting overwhelmed. And some folks who've blown the whistle on this and said that Sweden ought to have more of a lockdown approach have been targeted by trolls online. Some of the politicians in Sweden seem to be in denial about the whole situation, and some policymakers seem to be taking this rather cynical approach that everyone's going to get it eventually, so just let it rip. And then the final thing that I think is definitely worth mentioning is that there's an open letter apparently from 22 Swedish researchers who posted a critique of their current national policy, and they've been harassed as a result.
All right. Now, Kathy, would you like to?
Sure.
It's your turn.
Sure. Worried About Sweden writes that they were very disappointed to hear us uncritically accept the letters that we received praising the Swedish approach. So the majority of the Swedish public, 64% in the most recent poll, do approve. Many in Sweden have been horrified by how this has been handled, and many more in its Nordic neighbors are looking on with dismay as well. As of May 13th, Sweden, population 10 million, has now declared over 2,400 deaths, more from COVID-19 than all its three neighbors combined. That would be Denmark, Norway, and Finland, total population of 16.7 million, which only have about 3,000 more cases. As of today, that would be the 14th, it has 15 times the amount of dead that Norway does. Its deaths per million is among the highest in the world, even higher than the United States, higher now than Italy, and much higher than any of its neighbors. On April 28th, it was reported that some intensive care units were at 0% spare capacity. Sweden has had to import resupplies of a drug used in the ICU from Norway due to shortages. And I wondered what the article or what the drug was, and I clicked on the article and it was in Swedish. But as I guessed from the title, but after I did the Google Translate, the drug is propofol. More disturbingly, several whistleblowers at healthcare institutions have come forward to say that triage protocols were being inappropriately applied to the elderly and disabled individuals who have been denied ICU care and instead given palliative care, that is, left to die. It's well known that many of Sweden's deaths have occurred in elder care homes. It's been acknowledged by all those in power that this has been an abject failure of their proposed strategy of stratify and shield. However, it's become increasingly common not for those in charge not to take full blame, but to blame the situation in the elder care homes on recent immigrants, and cite some more examples of that. The authorities will outright deny that their strategy is herd immunity. When confronted directly, they routinely mention that herd immunity can be achieved soon in Stockholm and have been saying that it might come in May, and now it could happen in June. And the head epidemiologist, whose name is Tegnell, was asked who demands more action and believes that it is a fire that you shouldn't let burn. He replied, "It is as with forest fires and others. If you can just get it to burn a little and slowly, then you can get it to burn out," suggesting that they're enacting a controlled burn herd immunity approach. Watch what they do, not what they say. And what they are doing is implementing a very risky natural herd immunity strategy. Children who have parents with vulnerabilities are forced to go to school, even though this puts their parents at risk. If they choose to keep their children at home, they risk fines and possibly having their children removed from them by the social authorities. With only the bare minimum in regulatory mechanisms, Swedish social distancing adherence is starting to waver. Sweden's mobility does show a decrease when compared to its neighbors. It was never as far down as Denmark's, they must mean Denmark, Norway, or Sweden. Denmark, Norway, or Finland at any point. Even in light of its lack of formal lockdown, Sweden's economy is set to do as badly and perhaps worse than its neighbors. Treatment aside, test, trace, and isolate has been shown to work in several countries now, and that doesn't require either treatment innovations or ongoing strict lockdowns. There's absolutely no reason that most everyone needs to get this disease. Mike Ryan at the WHO was recently very critical of a herd immunity approach to this disease, and I think evidently this Mike Ryan was speaking more in general, but said Humans are not herds, and as such, the concept of herd immunity is generally reserved for calculating how many people will need to be vaccinated and the population in order to generate that effect. Meanwhile, in neighboring Denmark, the caseload has become low enough to reopen society to a very large degree while implementing this test, trace, and isolate strategy that has already seen proven success in countries like South Korea, Taiwan, Hong Kong, Singapore, New Zealand, Iceland, the Faroe Islands, etc. Denmark and Norway are in talks with 7 other countries that have gotten their caseloads down very far to form a travel coalition. One article on this proposed coalition specifically includes the line, "Sweden is not invited." Unfortunately, Dagnell has now come out and admitted that this strategy of test, trace, and isolate is not possible for Sweden due to how widespread the outbreak is. And then the overwhelming majority of Danish parliamentary parties are against reopening the border to Sweden, and he gives a link to a really interesting graphic. I'm writing you anonymously because in Sweden there is a principle called jantelagen, which means that anyone who goes against the grain is liable to be punished or bullied for defying the law of janta, which can be defined as conforming to the majority opinion and deferring to authority, almost with an unthinking deference. Most of those who have spoken out publicly have been viciously attacked, sometimes with quite vile abuse. A couple have shut down their social media accounts as a result. There may be some Swedish troll farms. Okay. It would be wonderful if TWiV were to interview one or more of the 22 researchers. I'm not sure who might be best, but if you all go through the list and find someone who fits TWiV, it would be great to hear them speak. In my view, Sweden's COVID response is akin to the United States' climate response, far outside of the scientific mainstream, dangerous and unethical. I truly hope that Sweden will change course soon, as I think there is still time to do what the other Nordic countries have done to get the caseload far down and implement the test, trace, and isolate strategy. But also, although that is in theory possible, it seems sadly unlikely due to the social dynamics at play. So that's from Worried About Sweden.
That's a disturbing letter.
Indeed.
Yeah.
Mm-hmm.
Yes.
So last time or last week, I guess we had a more positive letter, right, from someone.
Mm-hmm.
Mm-hmm.
And WAS is taking issue with that, right?
Mm-hmm.
Okay. Well, I would love to get one of these 22 researchers on. I'll see what I can do. I think it's a good idea. I'm sorry that I don't support our climate policy, by the way.
Right.
Hardly anybody does.
No.
No, nor do
people
I.
are in charge.
Ellen, do you want to summarize JR?
Sure, I'll take excerpts of JR's. Greetings from New York City, and a heartfelt thank you for all you do. I truly enjoy your podcast and have been recommending it to everyone I know. And you'll be happy to note they've expressed much gratitude for the recommendation. In speaking with several of my close friends in Sweden and in thinking about TWiV 611, I've come to realize the depth of the chasm between their current mentality and that of the rest of the Earth. My 3 latest working theories regarding the success of Sweden, and please note I certainly don't intend to offend or even slightly offend any Swedes. First, it's no success at all. The criticism is not that they're doing nothing, it's that they aren't doing enough and are letting the epidemic run its course. The implication is that they're voluntarily doing 90% of what their Scandinavian neighbors are doing, but their death rate is not even in the same ballpark as those neighbors, and then gives the figures that we just discussed above, basically. Indeed, Sweden's own Anders Tegnell, head of the country's response, who we've just heard about, has publicly stated the death toll really came as a surprise to us and is really something we worry a lot about. Second, effectively, they're free riding on everyone else's more severe responses. This is reminiscent of those who choose not to have their children obtain a vaccine, yet those children remain protected from disease due to herd immunity, or those who do not change their behavior but benefit from better overall air quality because many others make a concerted effort to reduce carbon emissions. Isn't it possible, maybe even likely, that lockdowns not only help each population group subject to such measures, but also help combat spread throughout the globe and therefore affect all of us? Third, if you put number 1 and number 2 together, Sweden is a dangerously unworkable model for other communities to adopt. All this suggests that the approach all countries, including Sweden, ought to follow is what TWiV has been advocating all along, and which has been relentlessly pursued by countries like South Korea, Taiwan, New Zealand, and others. Test, trace, test, trace, test, trace. Okay.
Well, unfortunately, countries are free to do, what they wish, right?
Correct.
Yeah. In the United States, even states are free to do what they want.
They are.
Indeed.
States are free to do
People
what
living
they
in the
wish.
states are also free to do what they want. And a lot of them are not following the official recommendations.
Right.
Which is
That's both in good and bad ways. There are some people who are staying home when they aren't required to, and there are some people who are going out when they should be staying home.
Kathy, I'm amazed at what's happening in Michigan. I am absolutely amazed. Are you?
So you're talking about the map that was in the New York Times?
Well, I'm just talking about the response from people living in the
right.
petitioning the governor to step down and all kinds of other stuff.
I've been stressing all day over the report that I saw about the legislature canceling a meeting because of fears of the armed protesters. Do I have that right?
I didn't hear about it. I don't know if it was. Yeah, it could well be.
I mean, Wisconsin is no better because they're trying to override the governor to get rid of her, and it's just crazy. It's just crazy politics all the way around.
Brianne, you're next.
Sure. Joe writes, "Hi, TWiV. I hope you are all well. I just wanted to ask a quick question regarding tennis and SARS-CoV-2. Here in the UK, the government has allowed singles tennis to be played between people who do not live in the same household. I wanted to ask if you had any thoughts about how the virus may or may not survive on the surface of a tennis ball. Would the force the ball is being hit at and or the high RPM of the ball have an impact on the survivability of the virus on the ball's surface? Best wishes, Joe." Well, I think this goes back to a previous letter about the fact that the virus might not move on the surface. It would still be about if you touched the tennis ball and then touched your face.
This has come up a lot in my household. My daughter is deeply into tennis and has been playing it since she was 5 years old, seriously. And the tennis academy that she attended up until March is in Connecticut. Connecticut reopened, so that's been closed, shut down this whole time. The Connecticut reopened public tennis courts for, I think, both singles and doubles play about a week ago. And my daughter has subsequently gone down there and hit with her coach. He can't open his tennis academy, but they can hit on a public court outdoors. And he's got protocols for all this. He's actually done a really good job. In fact, he's part of a coalition of tennis club owners in Connecticut who've put together a whole plan and petitioned the state to be among the businesses that are going to be allowed to reopen sometime next week, I think. The logic being this is a sport where the players can be 100 feet apart the whole time. And so they've come up with methods of dealing with all of this. And one of the rules is basically that when my daughter goes there, she touches essentially nothing but her own racket, and one set of tennis balls, I think, is set aside just for her to use to practice serves. Now, as soon as she finishes that, of course, she comes right home and I tell her to wash her hands, which she's already doing by the time I tell her. I think the risk, nothing is zero risk, but I think the risk involved here is extremely low.
If the virus got on the tennis ball, I think that based on something that I just heard from someone yesterday who's doing testing of masks and spotting virus on masks, and there were evidently two very similar conformations of masks, but they were made of different material. And the one where the mask was made of an absorbent material, just spotting the virus on the mask and then trying to get it back out, evidently in the first experiment gave much lower yield than the one that seemed to have a more shiny glazed kind of thing. So along the lines of, a virus on clothing probably being inactivated pretty quickly, on the tennis ball, it might be inactivated pretty quickly. And then.
But I think this idea that it's going to, the force of spinning is going to, that's not going to, the RPM, that's not going to do anything.
That's unlikely. Yeah. Right. But I think this is a very low risk activity that is appropriate for local areas to reopen with precautions. It shouldn't be, you should not be high-fiving each other. You shouldn't be standing right next to each other. But I think picking it up from the ball is pretty unlikely. And again, if you have this approach of, okay, I just touched something that is not part of my household, I'm going to treat that hand as unclean until I've had a chance to wash it.
I think you ought to play tennis by Zoom.
Right.
Or you could play with the garage door.
Well, there's Mario Tennis Aces on the Nintendo Switch, but
if you don't like latency, just try that. What was the thing? The website?
Mumble.
Mumble. There you go.
Did anybody see the picture of people, video of people playing? I think it was in Italy, across building rooftops.
Yeah. Yes, I saw that.
No, it was tennis. It was tennis.
Oh.
Yeah.
Wow.
It was amazing.
Resourceful humanity.
Mm-hmm.
Hey, Rich, you're next.
I want to start off by backing up a little bit because I said something about in Michigan closing the protests, squelching the legislature. It's here's a headline from CNN from May 14. That's yesterday. Michigan closes state capitol as protesters gather against stay-at-home order. So I don't think I read much past the headline. That implies that basically protesters are succeeding in closing down the Capitol. But if you get into the details of the article, it's not quite that straightforward.
Yeah, what I heard on the news this morning was that it was said to be a much calmer protest than the previous one.
Yeah, not only that, but this it's not like they chased out a pre-scheduled legislative session or anything like that. I think they were meeting remotely anyway, or so it's confusing, but it's not as bad. It's not as bad as I thought. Okay.
But it's still
people who write headlines really drive me crazy.
Yeah.
Well, they want you to read the article. That's why.
I know. No, they just want me to.
Body found in top.
They just.
Bar, yes.
Yeah. Oh. Okay. Sorry. Kathleen writes, we see a tremendous amount of information about face masks, but nothing about eye protection. If I wore, say, onion cutting glasses, would I have increased protection? I would be quite a fashion statement. Thank you for providing sane information. And there's a wonderful comment.
Well, she says, I want to point out, she says, if I wore, say, my onion cutting glasses, which implies she actually owns a pair of these, which I think is awesome.
Right. And Kathy has a wonderful little comment that says, this is a thing? Who knew?
Yeah, did any of us know it was a thing?
No, I had no idea.
I didn't.
Oh, wow. Amazon has multiple choices.
And they're not that expensive. I mean, come on.
I just cry.
So, I was thinking about the eye thing this morning because certainly I didn't fully appreciate what infection in the eye really entailed, which is, if I understand it correctly, if you were to get virus in your eye, there is the potential for it draining down your tear ducts into your nasal cavity, hence your respiratory system. It's not like it goes right in through the eye. It's just the eye has tear ducts that give you access to the respiratory system. And then I got off on evolution is amazing. Eyes are incredible to start with. We have to keep them moist, so we make tears. You got to do something with the tears. So you make a duct that goes down to the nasal cavity. I can't believe it. At any rate, anything that keep you from poking your fingers in your eyes would help. But of course, your nose and your mouth are still exposed.
Sure. Well, I think many places are having people wear face shields so you don't touch your eyes, right?
Mm-hmm. That's right.
Yeah, that for sure. Yeah, you could make a new fashion statement.
Could do that.
Anyway, did we even say they're not very expensive? Like $2.14 a pair.
That's what it says.
Yeah.
All right. What color are you getting, Kathy?
If they have purple, maybe.
Purple? Purple would be
must
good.
have purple.
I haven't found purple yet. Oh, wait, there they are.
Oh, good.
I think I'll just wear my regular glasses.
Yeah, that'll do the same thing. Yeah.
Yeah, I have winter goggles, actually, that are like face tight. Not as big as ski goggles, but they're probably the same kind of thing.
I have some swim goggles.
Yeah, there you go.
Oh, those are so tight, though, right?
But that's what you want if you don't want any of the vapors getting to your
really
eye.
uncomfortable. Yeah.
I have a scuba mask, too.
You could do that. Why don't you do that? Some people are wearing those around.
Yeah.
Yeah. All right. Dixon, you're next.
Chris writes, hello, everyone. London, Ontario, Canada, 1 degree C and sunny. Oh, I'm not supposed to read that part. So if roughly 80% are mild, why not do a controlled herd immunity strategy? Tell the high-risk folks to stay put, but allow the young and healthy to volunteer for a 14-day virus program. Infect, sequester, recover, test for antibodies, clear for ending quarantine. Rinse and repeat. Seems like sequestering people for 14 days and knowing they'll get sick, recover, and probably be fine after, and having the resources on hand in case they're not, is a whole lot better than an indefinite suspension of normalcy for something we're all going to get anyway. Exactly.
See Sweden.
Yeah,
Yeah, and I'm not sure that the sort of young and healthy people all recover and all have very easy disease course.
Nobody's at zero risk.
I don't think I'm young and healthy.
We're even talking about the questionable ethics of doing a challenge vaccine trial where you've got a vaccine that you think is going to protect them and then you infect them and you're using young, healthy volunteers. And that's dodgy in the current situation. So this situation where you're just going to round up apparently young, healthy people and get them exposed is really, I think, not the way to go.
Older people sheltered together and a young person happens to go visit them.
Yes.
You have a problem. So
that's right.
Mm-hmm.
Yeah. Trace. What is it? Trace, identify, trace. Identify, trace.
Test, identify.
Trace, test, identify.
Trace, test, identify. We have to do a
title. Test,
isolate.
trace, identify.
Isolate.
Have to do a title. Something.
Test, trace, isolate.
TTI. Yeah. I kept saying it because I didn't want to use the abbreviation. TTI.
Aaron writes, Aaron's from Texas. Can you please talk about how we can get to herd immunity if we are all sheltering in place? I can't rectify these seemingly divergent concepts. Why doesn't such extended shelter-in-place order mean boxing ourselves in to have to wait for the requisite years for a vaccine? Well, it's a good question. You can't get to herd immunity if we are sheltering in place, but if we don't shelter, many people will die, and the hospitals won't be able to handle it. So we're trying to reduce that load and bide our time until such time as we have therapeutics or vaccines, which admittedly are taking longer than we had hoped, or some had hoped, not me personally, but we knew that they would take a long time. But people want to get back to work, so we have to trace, test, and identify.
And isolate.
Yeah. And
test, trace, and isolate.
Yeah, I got to write it down. TTI.
Yeah, so Aaron, we're probably not boxing ourselves in for a vaccine, but we might need to wait for a lot more testing.
Yes, and I think the approaches that smart states are taking and smart countries is lock everything down until you've got your whole altogether now test, trace, isolate system set up, and you know that you're going to be able to get that working, and then gradually reopen, starting with things that are low risk or seem to be low risk, like tennis, and then see how that goes. If it's not going so well, then you just have to reclose those things. If it does go okay, then you can look at, all right, are we still seeing case numbers go down? Are we still getting this under control? Then we can go open a sort of a phase 2 and other things. And I am sad to report that things like gyms are probably going to be among the last things that we'll be able to open. But, we have to proceed with caution.
I just figured something out. Test, trace, isolate. The first 2 letters of each word spells out Tetris.
Oh.
Test, trace,
Nice.
isolate.
Nice.
So now we have the mnemonic.
Tetris.
Forever.
Good.
Tetris.
Now we have a title. All right, let's do one more round. Kathy.
Uh-oh, I zoomed up. Go to someone else next. Sorry. I was putting in
Alan.
the title.
Alan likes this one anyway.
Oh, I just zoomed up too. I can come back down. I'm coming back down. All right, we're on page 24, I think.
This is Ken.
Yeah, so Ken, oh yes. Why do so many American people elect such incompetent morons to their government? It seems to me that the USA constantly claims exceptionalism. It wages endless losing wars to support that stupidity, while in fact it's no better than a banana republic run by morons and criminals whom it seems are immune from any consequences. I know this isn't a virology question, but the incompetence and barbarism of American society, of its culture, has to be faced eventually. You cannot go on like this or you're finished. Cheers.
Wonder where Ken is from. Just curious.
Not here. I'm guessing maybe, well, couldn't be UK.
Cheers. Cheers, Australia.
Maybe.
Might be Canada.
Yeah.
Maybe UK. Ken, if you're from the UK, you shouldn't be too cocky about this. Just saying. If you're not from the UK, I mean, if you're a Kiwi, if you're from New Zealand, then okay, point taken, you got it. But
maybe he's just being sarcastic.
I don't know.
I don't think.
I don't know my wife.
I don't think
elect such incompetent morons. No. I mean, maybe if he is from the UK, he's saying that first line.
For sarcasm. Yes. Maybe. H.L. Mencken once said that democracy is the idea that the common people know what they want and deserve to get it good and hard.
That's great. Wonderful. Kathy, you're next.
Annie writes, what will destroy the S proteins on this virus, rendering it ineffective before entering the body, like on surfaces? Can the substance be put into a fogger that could be used in stores and homes? I won't take a vaccine. I will not accept the ingredients used to make vaccines. Can we focus on ways to stop the virus in other ways?
Chlorine. Just spray chlorine on all your
Lysol,
stuff, Annie. Go for it.
If you inject lysine into your veins, you will not catch this virus, I guarantee
let's be
you.
serious now.
Yeah,
Annie,
sorry.
We have vaccines because that's the way you prevent infection. Other ways do not work.
Other ways do not work, and they're more. If you had a chemical, I mean, I'm kind of baffled by this notion that you would rather spray the whole environment with a chemical that's noxious enough to destroy a protein on the virus, which, by the way, is going to destroy proteins on a lot of other things, like you. You'd rather do that than get a tiny dose of mostly natural proteins? I just do not see the connection.
So let me address the first thing. What will destroy the S proteins on this virus, rendering it ineffective before entering the body, like on surfaces? Well, if you thought that it entered the body only from surfaces, then you might have a shot at it. But what Christiana told me that Christian Drosten is now saying is that he thinks that 45% of transmission is aerosol, 45% is droplet, and 10% is from fomites.
That makes sense.
So if 90% of the virus is coming from some way other than from a surface where you might be able to destroy it, that kind of strategy is never going to work. And I agree with Alan, the idea of putting some really toxic substance into a fogger and spraying it around the environment and having everybody breathe that, or taking it in by contacting it and touching their face or whatever, is just extremely dangerous.
What about her comment about I won't take vaccines. I will not accept the ingredients used to make vaccines. What does she mean by that? What ingredients? There must be hundreds of different vaccines with hundreds of different ingredients.
Right. There's an article there's an article of faith in the anti-vax community that gets propagated on all these, now we know, very interlinked sites all across Facebook and such, that vaccines are full of hazardous chemicals and that this is what's causing all the ills of the world, and you'll see stuff about this all over the place and misinterpretations of chemistry in order to support it. It just doesn't jive with any of the facts. It doesn't make sense. And by the way, Annie, vaccines were the first homeopathic remedy, and they actually work.
Vincent, the article I was listening to today on the NPR was about anti-vaxxers with regards to the development of the polio vaccine.
Interesting. I should take a look.
So you'd enjoy the article.
Brianne, you're next.
Sure. Michael writes, could an infection by one of the 4 common cold coronaviruses confer a degree of immunity, perhaps temporary, to SARS-CoV-2? Might such infections also explain some of the false positives we now see in serological antibody tests? Is this possibly under investigation? And if not, should it be? So I think that this is something that some people are doing with their serological antibody tests. I know that we've heard from a few people like Stanley Perlman, who said he had been sending out a lot of the other coronaviruses that he hadn't used in his lab in a while because people wanted to do this sort of testing. So I think that it probably depends on exactly which antibody test we're talking about and how well it has been tested. And of course, there are types of immunity besides antibody immunity. I don't know that we've seen great immunity from the other common cold coronaviruses. There was a paper that just came out in Nature today that talked a little bit about T-cell responses. I'm not sure that we know enough yet.
But Stan Perlman said there's no cross protection, right? Between the common colds. But the cross reactivity in the tests, that's an issue, especially IgM, right?
Exactly. Especially IgM, which is going to be sort of a lot more promiscuous in its binding.
This is an issue that everybody studying this stuff takes into consideration.
Mm-hmm.
Cross-reactivity, cross-protection.
Right.
Rich, you're next.
Francois writes, where's she from? Is this, I don't know,
Wisconsin.
but she said Wisconsin. The temperature is currently 280.15 Kelvin. I don't believe that you have discussed yet this article on any of your podcasts, and references an article called Virological Assessment of Hospitalized Patients with COVID-19.
Actually, we did discuss it, yeah.
Okay. It was a while ago. I'm curious to hear you and your guests' take on it, as well as your assessment of the clinical significance of their findings regarding seroconversion and prolonged shedding. My reading is that transmission occurs most likely early in the course at a pre- or minimally symptomatic time, but that there is also potential for continued infectious shedding of the virus, which I infer they also seem to suggest is unlikely to happen from the fecal-oral route late in recovery. I would say, yes, that's my understanding. Suggestion, an episode of yours that I fabulously enjoyed featured both a tip-top title, No Restin' for the Weary, and a guest vying for the title of most interesting man in the world, in my opinion, Jens Kuhn. My goodness, Jens, are you listening? A podcast I recently started listening to, Conversations with Dr. Bauchner from the JAMA Network, featured another strong competitor for the title, Nicholas Christakis. The work that both of your podcasts have produced on the current pandemic has been superb, and I believe in sharp contrast, unfortunately, with the ambient low quality of the discussion. A crossover or collaboration would be incredible.
Who has low quality, us or Bauchner?
That's
no, the ambient coverage of this is low quality.
Okay. Aside from these outstanding podcasts, of course.
Right.
Anyway, Francois, listen to the Drosten podcast because he talked about that as well, because it's his work from the Munich cohort.
I was just going to say that they say they've been a long-time listener, hence I think they're giving us the temperature in Kelvin.
Yes.
Oh, yeah.
Yes.
And so he actually said that he saw a lot of negative comments on YouTube about the weather, complaining about the weather, and he strongly disagrees, as did the narrator's father in Proust's In Search of Lost Time, and then he quotes that at the end if you want to read it.
Anyway, I finally got a converter to give it to us, and that's 7 Celsius.
Nice.
Very good.
Right. Beth writes, I have a college student who may have contracted COVID-19 in late February. Her symptoms were very much like the ones described in an email read on a recent podcast, 104 degrees temperature, Fahrenheit, of course, coughing and fatigue for about a week. I hope she can get an antibody test, but I'm wondering how long after possible infection do antibodies remain in the system? The matter of if her college campus opens in the fall has an extra twist. She renewed the lease on her off-campus apartment and lined up a roommate for next year. There's no reason for her to stay there if the instruction goes totally online. What if the school stays closed in the fall and opens in January, or vice versa? More uncertainty on top of too much uncertainty already. And, of course, she hates online instruction. Thanks, Beth.
Brianne, how long do antibodies remain in the system?
Antibodies remain in the system actually for quite a while. It's just that there's a half-life of how many antibodies remain in the system. So she will probably have antibodies for months going forward. And she will have B cells that can continue making those antibodies, hopefully for most of her life.
So, Brianne, I got a polio vaccine 60 years ago, maybe or more. If you took my blood, would you still detect a little bit of anti-polio antibodies?
You may be an outlier, Vincent.
You've been boosting yourself in the lab.
So there
assuming I wasn't an outlier.
So there's actually a paper that looked at something similar with people who had gotten a smallpox vaccine when they were kids.
Yeah.
And looked at their ability to have antibodies and T cells. And there were patients where those antibodies or T cells were detected out to 75 years post-vaccine.
So probably a few B cells will just start making antibodies every now and then.
There should be a few B cells making some antibodies every now and then. You should have some level of antibody.
But this varies from antigen to antigen, doesn't it?
Yeah, I was going to say that.
Yeah, it varies a lot from antigen to antigen and from person to person.
Right. Which is why you need to get a tetanus shot every 10 years and so forth.
Yep. This issue of schools opening next year, to me, is one of the real critical issues that everybody is facing. Because that, universities and public schools, private schools are going to be an amazing incubation chamber. And how we deal with that, I don't know.
Well, they have to. They have to make plans. If, for example, if they don't have a fall semester, they have to make plans for people to get housing in the spring. Sure. It has to be done.
Yes.
Right?
Yes. And hopefully Beth's daughter's instructors have been in a whole bunch of faculty development about online instruction, just like I have this week.
All right, last one from Christina, longtime listener and fan. I'm writing to you with regard to the dose dependence in disease outcomes. I have to say, I pasted this in 2 months ago.
Lord.
Because that's when this arc was going.
Yeah.
Although it's
still a good question.
Yeah.
And we finally have got to this email. We're making some headway.
Yes.
Our lab actually does infectious dose studies of avian influenza in chickens and ducks. Poor chickens and ducks. We do this to determine if an avian influenza virus is more adapted to one species or the other. In our experience, dose and route of exposure can affect infection or disease outcomes. I'd like to share some of our findings in a shameless plug on a paper we published last year. When we directly inoculate birds with a particular virus, we only observe infection at the medium and highest doses. We get more or less the same outcome in both groups, that is 90% mortality and lots of viral shedding through oral and cloacal routes. On the other hand, the survival rate on the contacts of these groups was dose dependent. We know that the contacts were all infected because they became seropositive and they shed virus, although at lower levels. Our group is not the only one that have shown this phenomenon. We see this trend over and over again. My guess is that key difference is in exposures, since contacts get smaller doses multiple times instead of a bolus shot of virus up the choanal cleft, roof of the mouth. That's not where I thought it was.
No.
Maybe the immune system has more time to deal with the virus. Who knows? Choanal. Wow. Yeah, it's up there. She's right. Okay. So, yeah, I do think route and dose can determine disease outcomes. Would be interesting to see if that's the case for SARS-CoV-2, and she provides a link to her paper.
Yeah. And I actually have thought of another good example where the dose or route has a huge impact on pathogenesis, and that's variolation.
Yes.
Yeah, that's
right. So you take a shot if you scrape off somebody's smallpox scab and grind it up and shoot it up someone's nose who's not immune. They've got, what is it, Rich? Like a 1% mortality rate.
Well, actually, that was the original variolation was making a powder from a scab and putting it up somebody's nose. And I don't know that that was not a very safe procedure. And I don't know how good the data was. Ultimately the variolation that was practiced widely was taking smallpox containing material from a pustule and scraping it into somebody's arm, the same way a vaccination is done. And I've always thought that part of the reason, and that had about a 1% mortality rate, as opposed to about 30% from a natural smallpox infection. My interpretation.
So it was a terrible vaccine, but it was better than getting the disease.
My interpretation is the lowered mortality of that. Now, it may have something to do with dose, but also route of infection, because that virus ordinarily is acquired through a respiratory route. But if you scratch it into your skin, you get a milder infection. So, it could be either one. Could be dose, could be route of infection. And actually, it's interesting because there were people who practiced this were variolators, right? And there were good variolators and bad variolators. There were different, depending on who you went to, the mortality rate was different. And my understanding is that the shallower the scarification in the skin, the safer the procedure.
Okay.
Yeah.
So let me make sure I understand this paper. If they inoculated ducks directly with virus preparation, they got a high mortality. But if that virus was passed from one animal to another, the mortality was much less. Is that correct?
That's right.
Mm-hmm.
Okay.
Yeah. Survival rate on the contacts was dose dependent. I guess dose dependent of the original infected, right?
Yeah.
Right.
Yeah. By the way, it's 12 at this time of writing of this. It was 12 degrees Celsius in Athens, Georgia.
Okay.
I think it's warmer now, right?
Mm-hmm.
Probably.
Yeah.
TWiV 614 microbe.tv/TWiV for the show notes, which means you could read all the letters, full text, links, Kiki's comments. Questions and comments, go to twiv@microbe.tv. And if you like what we do, consider supporting us, microbe.tv/contribute. Dixon Despommier can be found at trichinella.org and thelivingriver.com.
That's right.
Thank you, Dixon.
You're welcome. You can find me on a living river, too. I'm going fishing Sunday.
Oh, good for you, Dixon.
The other night you were complaining that you're boxed in, but you're going fishing, man.
It's the only sport I can think of where there's absolutely no danger of running into another person. Because in trout fishing, if you look upriver and you see someone fishing, you just turn around and go back the other way.
Right.
You don't want to see people. You want to see fish.
That's the original definition of social distancing.
I think so. I think that's absolutely right.
Fisherman.
That's true.
Brienne Barker's at Drew University on Twitter, BioProf Barker. Thanks, Brienne.
Thanks. It was great to be here.
When are you coming back south?
Tomorrow.
Oh, good. You had enough, right?
Well, I need to get back so that I can take part in the Retrovirus's Cold Spring Harbor meeting on Zoom next week.
Yeah. Very good. Kathy Spindler's at the University of Michigan in Ann Arbor. Thank you, Kathy.
Thanks. This is a lot of fun. And I wanted to point out that way back when I had marked today, because it was that way in our Google schedule, that today was going to be TWiV 600.
Ah, cool. You still have that marked.
Mm-hmm.
Only off by 14.
Right.
Yeah, we accelerated a bit, right?
Yes.
Yep.
Wow. Rich Condit, Emeritus Professor, University of Florida, Gainesville, currently in Austin, Texas. Thank you, Rich.
Sure enough. Always a good time.
Alan Dove's at turbidplaque.com, and on Twitter, he is Alan Dove. Thank you, Alan.
Thank you. It's always a pleasure.
I'm Vincent Racaniello. You can find me at virology.blog. I'd like to thank the American Society for Virology and the American Society for Microbiology for their support of TWiV, and Ronald Jenkins for the music. This episode of TWiV was recorded, edited, and posted by me, Grumpy.
No, wait. It's Happy now at the bottom of the doc.
Yeah, but I can't change who I am, right?
But you said the other day that if we talk about virology for a while, you become less grumpy.
I do it. Yes, Thursday when we recorded, or Wednesday, whenever. At the top, I was very grumpy. And, it's funny, we have these Google Docs with all the show notes. And just before we start, we're typing. And I kept furiously typing to Kathy back and forth. And then finally, I deleted it all. None of this is important. And then at the end, when we talked about science, I was happier. Yes. So you've been listening to This Week in Virology. Thanks for joining us. We'll be back next week. Another TWiV is viral.